You just received your minutes, so we won't be approving those until after lunch. So take a look at those when you get a chance. And then, of course, when you have time, sign your vouchers and hand them over to me. I appreciate that. Today, I believe we have Senator Hawk on WebEx. I don't know about the other senators or representatives. So we will begin. And again, like I said, we'll approve those minutes after lunch. So we're going to begin with the behavioral health workforce in rural America, and it'll be virtual. And we have Nancy Baum, the Health Policy Director, Center for Health and Research Transformation. Nancy, are you on WebEx and live?
I am. Can you hear me?
Well, we see you, Tom Hawk, but that's not who we're looking for.
I'm Nancy Baum. Can you hear me?
I can barely hear something.
Okay.
Nancy, can you speak to us so we can see if we can't get that sound adjusted?
I'd be happy to, Senator McGinn. Now?
We can hear, and are we supposed to see you or not?
I do have my camera on, but I'm happy to have you just listen if
There you are. Now we
video.
see you.
Hello?
Great. We're good.
Good.
Thank you.
Happy to be with you, and my colleague Jackie King is here as well. Can you see and hear Jackie?
Hi, good morning, everyone.
See Jackie too. All right, well, I'll let you go ahead and begin.
Terrific. So Jackie's going to share her screen. We have a few slides that we'll share with you and then leave a few minutes at the end for questions if you're interested. Can you see our slides?
We do. And we have a copy as well.
All right. Sorry about that. I was having trouble unmuting. So as Nancy mentioned, we're going to present the behavioral health workforce in rural America. And I have a presentation overview. Just kind of wanted to give a brief introduction so that Nancy and I could introduce ourselves. As I mentioned, I'm Jackie King. I'm a senior project manager at the Center for Health and Research Transformation, or as we refer to our acronym, CHART. I've been working in the health policy analytics space for the last 10 years, and I've been involved in a range of focus areas, including the cost and use of healthcare services, community efforts for the older adult population, preventive services for people with disabilities, long-term services and supports in the state of Michigan, and the behavioral health workforce. Nancy, do you want to give an introduction briefly?
Happy to. Hi again, everybody. Nancy Baum. I'm Director of Health Policy at our center. I started my career as a psychiatric nurse in an inpatient setting working with adolescents. And so since then, behavioral health has been a very important part of my work, although I focus on policy issues. Yeah, I'll turn it back over to you, Jackie.
Thanks, Nancy. So the first part of the presentation, I'm going to talk about our behavioral health workforce in rural America study that we conducted in 2019 and published in early 2020. Just to give a brief overview, our study was focused on recruitment and retention efforts for the behavioral health workforce, specifically focused in rural America. The study we conducted was in conjunction with the Behavioral Health Workforce Research Center at the University of Michigan, and it was funded by the Health Resources and Services Administration, or HRSA. So over the course of 2019, we had conducted 75 interviews across 47 states, so almost representative of all states. We talked to a few experts in each state to represent rural health offices, as well as offices of health workforce and mental health agencies, so that we could get a mix of both a perspective specific to behavioral health and one specific to rural health. The main purpose of our interviews was to learn about recruitment and retention strategies of behavioral health workers for each state, as well as any challenges faced in each area. We conducted qualitative analysis through NVivo software and aggregated individual interview transcripts to identify key themes. From this work, we then published 3 main publications, including a toolkit of resources, policy brief, and full report. And I think those materials were shared with this group as well. This is just an example of some of our interview questions that we asked across each state. And generally, we asked each expert what kind of strategies were being employed, as well as any challenges or barriers they faced with recruitment and/or retention. We then ended each interview by asking interviewees what else they would do if they had the resources to do it. This question gave us really unique information about the kinds of strategies interviewees felt would be most effective. And one of the things I'd like to just add here that I think is important to note is our toolkit and report does talk about some of the things that we learned regarding telehealth as a key strategy to recruitment in rural health areas. And I think it's important to note that this was pre-COVID pandemic, so things like that could have changed quite a bit since then. The next slide details some of our key findings. Across many of our interviews, we learned that there was generally a lack of data, both in terms of which behavioral health providers were in the greatest need in the state, as well as which recruitment or retention strategies were most effective. Many of the responses we received were based on anecdotal evidence and perceptions, so based on that expert's perspective and experience. Many interviewees did report that they thought psychiatrists were in the greatest need in their state, but really all levels of behavioral health professions were reported to be in high need across many of the interviews. Most interviewees did express the need for increased financial incentives, including raising salaries and Medicaid reimbursement for behavioral health services as an effective way to recruit and retain workers. Other financial incentives that we learned about through the course of our study included tax credits and scholarships. At the time of our interviews, one state had pending legislation to reduce physicians' tax liability up to $25,000 per year for practicing in rural areas. And then 18 states reported the use of scholarship programs to recruit providers. Many respondents also suggested a greater investment in pipeline programs, and loan repayment programs may go the furthest to address the gaps in rural recruitment and retention of behavioral health workers. This was seen as being one of the more effective strategies. Loan repayment programs in the states may have included a combination of the National Health Service Corps, or the NHSC, state general funds, or private entities. Nearly all interviewees indicated loan repayment as an important tool for recruitment. However, some programs were harder to access because they required matching funds, such as the NHSC state loan repayment. And then for pipeline programs, these may happen at the middle school or high school level or college levels. Many of our interviewees were enthusiastic about their pipeline programs, but few of them knew of ways to track actual recruitment. Tracking information about these participants over many years was difficult. This may have also been due to participants in the pipeline programs being minors, and so having parental involvement would have been needed to do any sort of tracking for recruitment. Several interviewees reported that residents tend to stay and practice where they complete their residency. So it is important for states to have residency programs for psychiatry as well as other behavioral health professions. However, most of our interviewees reported that their states were not increasing residency slots. A lot of that was due to funding limitations. So next, we also looked at and identified several innovative approaches that we heard from states in terms of recruitment and retention efforts. One of these approaches was the development of state programs that coordinated with foundations or community employers to fund additional programs such as loan repayment. So really that public-private partnership was seen as an effective and unique approach to be able to fund these additional programs. There were also innovations in some of the pipeline programs that we learned about. These included an extended role for a preceptor who would remain in contact with the students so that they felt connected well after their pipeline program experience. Some of the programs also included rural rotations for advanced practice nurses or medical students. And then other programs plan to offer behavioral health specific training, such as mental health first aid training or peer support training. Another innovation was encouraging early entry into practice. And this was actually one of the innovations that we also heard from our Kansas interviewees. At the time of our interview, one of the Kansas interviewees had mentioned the state was considering tiered certification so that more people could join the behavioral health workforce earlier in their training by reducing the requirements for social work, nursing, marriage and family counselors, or others to fill these entry-level positions. And then in terms of improvement to work-life balance to reduce burnout, several interviewees talked about job sharing and other flexibility, such as moving from 8-hour shifts to 12-hour shifts. One expert had an interest in a tool called a community APGAR. It was a way to assess how attractive a community is to providers in rural areas. And then, as many of you may be aware of the behavioral health recruitment and retention in Kansas, I wanted to spend a little bit of time focusing specifically on what we learned in your state. For the state of Kansas, we had talked to 2 interviewees at the time. One was Cynthia Snyder, who at the time of the interviews was the Director of Special Population Health, Primary Care, and Rural Health. And then we also talked to Andy Brown, who is the Interim Commissioner of Behavioral Health. So some of the barriers that we learned from our experts in Kansas related to recruitment and/or retention included licensing requirements for social workers, competitive wages and financial stress, family support, such as having jobs for spouses and available childcare in rural areas, and lack of available proctors for students. These barriers were also present across many of the states that we talked to throughout our study. However, there were also several strategies and innovations we heard from our Kansas experts. Both experts mentioned loan repayment programs and J-1 visas for international students as strategies used for recruitment and retention. Another strategy was the use of shorter work weeks, where some positions may offer 32-hour work weeks instead of 40-hour work weeks, but still being paid at a full-time rate. And as previously mentioned, our experts also mentioned Kansas was exploring the use of tiered certification at the time of our interview to allow for earlier entry in their career. So I'll stop here. Going to pass it over to Nancy next for the next part of the presentation.
Thanks, Jackie. So in addition to the approaches to recruitment and retention that Jackie talked about from our study and from our findings from talking to your experts in Kansas, just wanted to present a little bit broader framing of ways to address the actual problem that I think you and virtually every state in the country is trying to address, which is the fact that there's demand for these inpatient beds, inpatient psychiatric beds, that is too high for supply. One of the most important things, and in fact, if you take one thing away from this talk, it might be this, that fully half of all behavioral health services are provided in primary care settings. Half of behavioral health services are provided in primary care settings. So anything that you can do in Kansas to shore up your primary care providers and the settings through which they deliver services, you're going to help address the behavioral health needs in your communities. So, for example, in federally qualified health centers, in your new CCBHCs, certified community behavioral health clinics that I know you're beginning to establish in Kansas as well, and other places where integrated care is delivered. So somebody might come in to a primary care setting, but during their visit, they can actually receive behavioral health services. And that can be done because the primary care provider, him or herself, delivers, can, for example, prescribe, psychotropic medication, or it may be because they have, as a part of their clinic, a mental health professional whose office is just down the hall, and then there's a warm handoff from the time of the primary care visit. So what you've done here is reduce the stigma associated with going directly to a, specialty behavioral health provider. You've also created an opportunity for the primary care provider to understand the full breadth of the health issues that the individual is dealing with. So delivering behavioral health services in primary care is a great way to reduce that demand. And just like any kind of healthcare, when you deliver services sort of early, for preventive, this is a level of prevention that then many more individuals don't end up needing to be an inpatient in a psychiatric setting. So it's important to think about reducing demand in this way. I would like to add that VA clinics in every state in the nation have had decades of experience doing this kind of delivery of what we call collaborated care. So receiving behavioral health services in primary care settings. And VA clinics just have an enormous depth of experience here, and you might consider reaching out to folks in VA settings in Kansas. And then in school settings in general, I'll give you an example of a program that's referred to or called TRAILS. The TRAILS program trains counselors in schools to deliver certain kinds of services to kids. This can be middle school, high school, even earlier, where they can help to intervene very early on and identify behavioral health issues that kids are dealing with. They can deliver different kinds of cognitive behavioral therapies and things that the training is not extensive, and it has an important sort of train the trainer element to it. So this Trails program, which started here in Michigan, but now is in lots of other parts of the country, and is also, there's actually some international interest in it. It's run by a woman named Elizabeth Koshman, and the evidence for, cognitive behavioral therapy is really good. And so providing this kind of programming in schools, again, can help reduce the number of kids who end up in emergency departments and who end up needing inpatient psychiatric beds because of earlier intervention. Another thing to think about is that there's this terrible issue in behavioral health services um, that really is complicated to address, but there are certain things that can be done, and that is that there is a very high no-show rate for people who are seeking behavioral health services. So we don't have enough psychiatrists. You schedule them, and then a third of their patients don't show up that day. That's a really difficult situation to be in, and one that if we could address the high no-show rate, you may not need quite as many, for example, psychiatrists, as you do need. So, for example, transportation support is one way that some regions address no-show rates. Telehealth, which of course, to Jackie's point, telehealth has changed a great deal. But anything that you can do in rural areas, for example, to shore up the infrastructure that's required for people to actually use telehealth services. This is another opportunity to reduce no-show rates.
Nancy,
Go to the
before
next.
you,
Yes.
this is Senator McGinn, before you
Yes.
change slides,
Yes.
there was an awful lot of information disseminated on that one
Okay.
slide.
Yes.
And where will we go to find that information? Would we
So
go to
Jackie, can you go back to that slide that Senator McGinn's talking about? So, let's see. Specifically, if what you're looking to do is get more information about integrated care services, so behavioral health services being provided in primary care settings, you can go to the Organization of Federally Qualified Health Centers. You may have one in Kansas. There certainly are some national organizations. The individuals in Kansas who are setting up the new CCBHCs, I think when I looked last, you were approaching something like 20 or more of these integrated care settings in the state. And so you might go to the leadership setting those up. And again, in the VAs themselves, most VA hospitals and health systems have specialized behavioral health services, but they also have people in primary care who are responsible for those integrated services. And so, I think if you would talk to the behavioral health director at a VA, in a VA health system, you would be able to be put in touch with the people who have all that expertise in delivering collaborative care and other models for integrated services. The Trails program, Elizabeth Koshman, and we would happily send you her contact information. She's a psychologist by training who started this Trails program. And this is where they go into schools and they train the counselors and people who are already on staff at those schools and already know the students. And when students present with behavioral health problems, they are then trained to address the kids' problems in a whole variety of ways, not just cognitive behavioral therapy, but other approaches as well. So happily send you Elizabeth Koshman's contact information. She is now a nonprofit organization. She had been an academic at the University of Michigan, and now Trails is a nonprofit organization itself. So is that helpful for the integrated care services?
Yes, thank you. I wanted to make sure everybody knew where they could dig deeper if they wanted to.
Yeah. Yeah, great. Okay. You want to go to the next slide, Jackie? So I'll just add a few more things. I know we're bumping up against time here. Diversion services in jails is a really important place, again, to intervene early so that you can find people who have an interaction with the justice system, but in fact, their primary cause of that interaction might be a mental health issue. So in Michigan, for example, recently we've looked at some data and we can see that individuals with mental health problems stay in our jails many, many days longer than people who don't have mental health problems. And so there are programs that have been in place for quite some time in many areas, and you might find out what's going on across your state. But there are programs where professionals from your community mental health organizations are in the jails to do early assessments for people who present to the jail, but the people running the jail might say, I think this person needs to be assessed for a mental health issue. And that way, if they aren't already enrolled with the community mental health, they can enroll immediately and begin getting those services, often while they're in jails. The information can also be shared with the judges and others who are making decisions about that individual's experience with the justice system. And so jail diversion programs are a very important way, again, to, excuse me, enroll people in the services that they need early, and so that they appropriately get those services before they end up needing to be an inpatient and take up one of those precious mental health beds.
So Nancy, are you
Yes.
specifically talking about your state? Because we don't hear that we have good diversion programs because we're very short staffed, and that's part of why we were having this interim, is trying to figure out where to put people when they do come in crisis.
Right, and
So
so I think what I would say is that states like Kansas have an opportunity to support a community health worker who could be available in the jail systems to do these kinds of assessments. So yes, we do this in certain places in Michigan. We don't do it everywhere. And Michigan is not alone in this. Many states have these kinds of diversion programs, but as to your point, it really takes additional resources. So there are people who work in community mental health who already work very closely with your sheriffs and others because there is this known overlap between involvement with the criminal justice system and mental health issues. And so you might have an opportunity to put in place a diversion program in a place where the community mental health and the sheriff already work well together. And as I said, this is an opportunity for early screenings and assessments so that if somebody is in the jail, but really what they need are mental health services in addition to whatever services they're getting through the criminal justice system, then those can happen earlier on.
we have a question from Representative Laneware.
Sure.
Thank you, Madam Chair. I guess I'd be kind of interested in what your diversion services look like, because just to give you an idea from where I live at, we do
Yes.
have CCBHC in place.
Yes. Uh-huh.
It's fed by the county, but what does this diversion look like? Because you're dealing with the mental health side, you're dealing with the court, the law enforcement.
Yeah, we'd be happy to send you some information about jail diversion programs. I know that there's some published information about the opportunities that diversion programs have. I can look and see if there's anything that is already written about our own local, in our county, for example, where the sheriff and the director of the community mental health work together very closely. They probably talk to each other every day. I can find out if there's anything written there. I also will say in our particular county, we have passed a mental health millage very recently. So there is extra funding in the system to address these very kinds of programs. So that's not something every community obviously can do, but that is one option that has happened in, I would say 4 or 5 communities in the state of Michigan now have passed specific millages for mental health services.
Okay, I'm not following. What is this program you're talking about that you've passed for extra funding?
A millage, so this is a local
A
tax.
mill levy.
Yeah, are you not hearing? Is it hard to hear me?
The interpreter on what we're trying to read when we don't hear you, it came up village instead of millage. So I thought maybe we just needed a village. So
That's, you know what? Yeah,
Yeah,
that is
we
an
don't need
interesting.
any villages. No, I think I would be interested in seeing what you're doing from the diversion, because I know that our sheriff would be, very excited to see how we could divert some of these um, individuals as well. So,
Terrific. Yeah, we will
thank
see
you.
what we can share information on that. Yes, happy to.
All right,
The
thank you.
other thing, you bet. The other thing, very quickly, I wanted to talk about is something that we refer to as complex systems modeling. This is something that is led by an academic named Kristen Litch, Lich, at the University of North Carolina. And what she does is she builds a model, and then she gets data from a local community, from health systems and from the community mental health organization. And she populates her model with this data. And then she can say, for example, and there are a bunch of assumptions in the model because, of course, there isn't complete data for everything. But what this model helps you do is to say, okay, well, in the city of Topeka, if we added 3 additional ACT teams, so assertive community treatment teams, the impact would be there would be an estimated impact from this model on the demand for inpatient beds, say, or for the impact on how many fewer people might use the emergency department. So it's a way of saying, if we make this investment in our community, what do we expect the impact of that investment to be? And it's a very exciting new approach that she's using, and it's time intensive, and the particular effort that I'm aware of and a part of now actually is being funded by a private donation. And so it's another way to think about how to get more information about what changes in our system we could really, sort of what impact we could expect from these changes. So if we added a psychiatric emergency department where there isn't one, or if we funded 3 more assertive community treatment teams, what do we expect the impact to be on our inpatient psychiatric settings? So it's modeling, but it is using real world data. And so this is a very exciting sort of new approach to, ways to think about where to make investments. So just one more slide, Jackie, I think.
Nancy, we have another
Yes,
question here.
sure.
Representative Wolfmore.
Yes.
Thank you very much. So my questions go back to the first part of the presentation. So
Okay.
one of the key findings was most experts agree that raising salaries, improving Medicaid reimbursement will positively impact workforce, which I absolutely would agree with that based on what I've heard. But are there states that are leading the way on that and having some success with that?
So I don't know, Jackie, I'll just make my contribution and then I'll go on mute so we don't echo to each other. But I think that what we would say from our study is that, in essence, very few states have evaluated their efforts. So they're doing this, but they're doing this and then looking more anecdotally at what their response to that is. So I'm not sure that I can identify a leading state. Is there any that you would point to, Jackie?
Sorry, I was on mute. I think I would also echo what Nancy was saying. I think that it was definitely difficult, and that was one of the challenges that states faced was being able to raise salaries and have competitive wages. And it also kind of depended on funding resources. Our report aggregated all of our transcripts together. So I think we'd have to go back and look at some more detail to see if there were any particular states. But yeah, I don't think I have a clear answer on specific states.
And I would imagine, thank you very much. And I would imagine that CCBHCs will, those states who have adopted those will continue to be able to raise salaries because of the increased funding. But so that would certainly be helpful. My other question is on recruitment and retention. One of the barriers that you briefly talked about was licensing requirements for social workers. Are you talking about the continuing ed they have to do in order to keep their, could you expand a little more on that maybe?
Would you like me to do that, Jackie?
Sure.
So at the time of our interviews, and again, this was a few years ago, in addition to the educational requirements for social workers, there was also, I believe it was a 2,000 hour requirement for experience in the field before a social worker could be licensed to deliver the behavioral health services that they were trained to deliver. And so there are states and there are opportunities, I think, in Kansas, if you're not already doing this, to think about whether that 2,000 hour requirement is the standard that you want to continue. I think that when we were doing our interview a few years ago, we had a brief conversation about the fact that that might have been a higher number of hours than other adjacent surrounding states had, as compared to what you were requiring in Kansas. So there are these opportunities essentially to put professionals in the field earlier. What you might do is have a requirement for a mentorship or oversight, for example, in addition to a lower number of hours. But again, you know, this requires having the individuals who can do the oversight as well. But that's an example. It was less about continuing education for an already licensed professional and more about what does it take to actually get somebody in the field a little bit earlier.
Okay, and I definitely get that. The only reason I ask about the continuing education, and I don't know what the status is for Kansas, but I know years ago, I used to be, well, I guess I still am an MSW, but it was so onerous to keep your license if you weren't working in the field. So I think sometimes we lose people who phase out of the field and may want to come back, but at the time in Kansas, at least, it was very onerous and very expensive to keep your license updated. But we'll have to see what the status of that is in Kansas. Thank you very much. Thank you, Madam Chair.
Right, and
Representative Landwehr.
Well, and Representative Wolf Morris, we have instructed the BSRB to be looking at where we can do reductions. The one thing I hadn't thought about in those discussions was CE time. And so that's something we need to add to our list as we move forward. Thank you.
Go ahead, Nancy.
All right, I'll just make a couple more points and then we'll wrap it up for any other questions. There are a couple of other workers who I'm referring to here as sort of extenders to the behavioral health workforce. Community health workers and peers are important for a number of reasons. Community health workers in particular are of the community that they're serving, and so they understand the resources that are available to people. They understand how to do things like reduce transportation barriers and how to connect people with behavioral health services early on when they're identified. And so, and peers, of course, have experience with, we often use the term peer for people with a history of substance use disorder themselves. And so they have experience in a way that they can then sort of walk hand in hand with individuals who are trying to navigate what is a very complicated system in order to get the behavioral health services that they need. And then finally, you're probably familiar with medication-assisted treatment, which is a particular approach used largely for opioid use disorder. And it's an evidence-based intervention, but it's an intervention that many primary care providers in particular um, are not providing. And it's a very complicated set of reasons about why they're not providing those services. But I wanted to tell you about an innovation that um, these are not public dollars. These are dollars from the insurance system. But Blue Cross Blue Shield in Michigan is offering, if primary care providers will get trained to deliver medication-assisted treatment, and that requires a waiver of training. It's like I think it's an 8-hour training. It's not a lot of training. And if they'll see X number of patients to deliver the MAT, they have a $10,000 incentive per provider. And so this is a really significant opportunity that's funded through the insurance industry um, that larger insurers in Kansas might consider to incentivize providers to deliver MAT. Again, when people with opioid use disorder are treated appropriately in a timely way, they are going to be less inclined to end up in the emergency department or need an inpatient bed. And then, another aspect to this would be just to consider who in Kansas can deliver medication-assisted treatment and whether advanced practice nurses and physician's assistants could do that. Again, another opportunity to provide sort of appropriately timely services to people and hopefully reduce that demand. So I believe that's all I had. And again, we'd be happy to take questions if you had any additional questions.
Questions? Yes. Representative Waymaster.
All right, thank you, Madam Chair. And I'm going to go back to the previous slide where we were talking about the sheriff's departments and kind of bridging that gap between the mental health centers.
Yes.
And the area that I represent is a very rural area in the state of Kansas where I live.
Yes.
And one thing that I have been hearing overwhelmingly from the sheriff's departments is, I don't want to say a lack of response time, but the regional community mental health center that handles numerous counties in our particular region, there is a lack of service, and they have the sheriff's departments are feeling that there's a very slow response time. So in other states who have rural areas, how have they been able to bridge that gap and increase the response time to the sheriff's departments if those individuals are sitting in a county jail?
Yeah, I don't have any examples for you per se, except for the one that I know best, which is my own local county. And I think part of the reason that there are a lot of things going on there. So really importantly, the relationship between the sheriff and the person that runs community mental health needs to be a good relationship. It needs to be a working, high functioning relationship. That isn't the case in every community. So something to explore there. I think that, in terms of response time, if they're referring to how long does it take for somebody from the CMH to come to the jail to do the evaluation, I think, that would have to do with the staffing at the CMH, presumably, unless there were other barriers to allowing people to come in and do this kind of evaluation. But I'm not aware of any sort of best practices other than, the things that I've referred to, like in our community, we actually have passed a millage that raises funding that's specifically for things like supporting staffing at the CMH so that they have enough people to go to the jails and do the evaluations.
Okay, thank you. And then the next question I have is when you mentioned that there are certain private foundations that assist in funding, and I'm kind of intrigued by that because we have a large foundation in Northwest Kansas that services about 28 counties in Northwest Kansas, and their main focus is rural economic development. But this could also cascade into mental health as well if you can find personnel to move to a rural area and stay in that rural area. And so I'm kind of intrigued about exactly what that partnership looks like with a private foundation.
Right. So I think there are a lot of opportunities there for private foundation involvement, private funding. So, for example, you could create additional loan repayment programs. You could create, um, uh, funding for things like that complex systems modeling that I was talking about, so that you could sort of better understand how, if you tweaked your system, your mental health system, where would you expect to see impact and how much impact? I think there are lots of opportunities for those public-private partnerships that really, I think, is what we're talking about. And I don't know, Jackie, if you have more to add from our interviews, but we did hear a number of places where, something similar to what was being funded using public dollars could be augmented by private dollars doing something very similar. A private foundation could fund a pipeline program in your communities. They could come to the table with additional incentives to bring providers.
Yeah, and I'll just add to that briefly. So one of the states that we had talked to mentioned seeking out foundation funding to pay for student nurses during their rural rotations in federally qualified health centers or substance use facilities, or providing needed transportation and housing allowances. So those were another couple of the opportunities that the state experts had for use of funding with partnerships with private foundations.
All right. Thank you. Thank you, Madam Chair.
Thank you. And I appreciate the dialogue that we've had with all of you. We've talked about some programs we've had in the past. One had to do with grow engineering in our area because we needed it at the time. And it also was kind of a private public program, and the fact that we did use our universities, but alumni and others had a chance to donate to grow that as well. And so, so this is great to hear that this is something that is being done elsewhere that would give us an opportunity to model after. Any other questions for Nancy and Jackie? I think it was this time. Okay. All right. Well, thank you. Appreciate your input.
You're welcome. Happy to speak with you, and we'll connect with Megan to see if we can provide the resources that a couple of people asked for.
Thank you.
Thank you.
At this time, we'll turn our attention to staff training and preparation at state hospitals. This will be virtual. We have Dr. Mike Dixon, the State Hospital Commissioner for the Kansas Department of Aging and Disability Services. Welcome, Mike.
Good morning, Madam Chair, members of the committee. Lee, can you put the presentation up? Thank you. Okay, I'm going to talk a little bit about training for the direct care positions at all the state hospitals. And what I'm really referring to as we go through this is training for our MHDD techs, the people right on the ground, our activity specialists and therapists, our client training supervisors, our LMHTs or licensed mental health technicians, our licensed practical nurses, our mental health professionals, our registered nurses, and our safety and security officer and our chief of security. To be an MHDDT, that's really the meat of this presentation. Which is an entry-level position. It's people who work with the individual residents, patients, day to day. They must be 18 years or older. That's the only requirement. There are things like background checks and drug tests, things like that. But as far as the criteria for the job. They must be 18 years or older. And interestingly, they also cannot be in high school. They have to be out of high school. They don't necessarily have to graduate, but they can't be attending high school. Each hospital has its own in-house training. And over the years, the programs have been created separately. However, there's a lot of similarities between all four of them. Lots of things that are very similar. It takes approximately 80 hours of training at each of the hospitals, and on average, 5 to 10 of those areas, or 5 to 10 of those hours, are actually working with patients, residents on their living units. I'm going to walk through Parsons and LSH's curriculum. KNI and OSHA's is very similar. And Parsons is very similar to LSH, but I was going to walk through these two to give you an idea of what it looks like. At Parsons, the first thing that they really go through is human resources, and that's really just making sure they have a knowledge of their conditions of employment, how much they're being paid, what their benefits are, their insurance, EEO information, work comp processes, know how to fill out staff injury forms, things along that nature. Then we go into staff development training. And what we're really looking at there is just the overall culture of the hospital, our vision, our mission. And then at that point, they're going to meet their supervisor. So we take a little break from the training, they go out, they meet their supervisor, and then they come back. And they go over what the training requirements, what's going to happen over the next couple weeks. Information security awareness is taught during this section. We start to introduce them to, so they have an understanding of the rights of the individuals who receive services. Introduction and teaching of our policy and procedure manual, the do's and don'ts of basic interactions with the people who live here, impact on person first language, an introduction to the advocacy group at Parsons. And then at that point, they get a campus tour, they get their keys, they get their employee ID. Then they go into risk management, which is really just what is risk management and what are the reporting criteria. You know, what should they report to risk management immediately? Then we go into infection control, really just an understanding of universal precautions, making sure they know how to correctly wash their hands, you know, really some basic things. At this point, also how to don and doff PPE if necessary. And then they get a tour of their work area. They go and actually spend some time on their work area. They get to spend some time with the CTS, the client training supervisor, their program coordinator, person in charge of the living unit, to get an idea of what they're going to be doing on a daily basis. Okay. Then there's some education on speech and language, and it's really just an understanding of communication supports and assistive technology, if any, is used on the units they're going to be working on. Then staff development, understanding what, you know, any of our emergency procedures that we have in place, how to document noteworthy occurrences, any workstation information, you know, logins, things of that nature, a demonstration of HIPAA. And there's also some online manuals at that point and courses that they're going to have to take and pass. And then some training and a demonstration of sexual harassment policy. And there's also an online module for that. Human resources again, and that's really just making sure they know how to log their time. At that point, then they meet with a COAST rep. And then they go into, and this is done by our nurse educator that we have on staff, and they become, if they're not already certified in CPR and first aid, they go through that training. We started trauma-informed care we're actually implementing this at all 4 campuses, but we start to introduce it day 1 at Parsons. And then we really get into a 2-day crisis prevention, intervention, and nonviolent crisis intervention training. We refer to it as CPI, NCI, and that's really how do you stay out of safety holds or restraints with the individuals who live here. It's a lot of upfront training, so they just have a good knowledge base of how to not get in harmful situations. But it also, the last section of it is to give them training on how to safely place people in safety holds if they have to. More intro to the hospital, that's more cottage tours, spending some time observing, following around other MHDDTs, other people, other activity therapists, whatever position they're in. And then we go into positive behavior support training, which is really pretty involved. But it's giving staff those tools that they need to work with people who have some pretty challenging behaviors. We also have different levels of training based on what position you're in. We have an outreach team at Parsons, and they several of those staff are master's level people, they're psychologists, and they get what is called a BCBA, or a board certified behavior analysis. And that is advanced training in behavior analysis. What those folks do is they spend time in the community trying to keep people out of institutions. So when we get a referral, they go out and try to stabilize the behavior in the community, so they don't have to be admitted to any of our 4 hospitals. That's at the master's level. At the bachelor's level, we have what's called a board certified associate in behavior analysis, and it's basically the same thing, but it's a little less advanced than the BCBA. And we're in the process of opening up a behavior stabilization unit at Parsons, and we're doing with all the staff there. They will go through all the training that I'm talking about during this presentation, but they also, we're requiring them to get an RBT, which is a registered behavior technician. It's a certification, it's 40 hours, and they have to take a test, and then there's some observation that has to be done by a BCBA before they can get their certificate. Then we, more with supporting, communication, more training on assistive technology, supporting health and wellness. That's really just health concerns, health training, what to look for, knowledge of different things like diabetes, seizure disorders, recognizing signs and symptoms of illnesses. And then on the very last day of the 2-week training, we do a leadership Q&A, and all the leadership staff of the hospital meet with all of our new employees, and they just ask questions, things that they've seen during the week that don't make sense, questions that they have, just to follow up.
Mike,
Yes, ma'am. Yes.
Senator McGinn, before you flip the page, you just finished by saying basically what's on page 4 is 2-week training, correct?
Yes.
You also, though, flip back and forth when you talked about some of these bullets. That person was a master's level or not, and I'm trying to understand the MHDD technician. Are you telling me that some are 6 months trained or educated, some are master's level?
No, I
I'm
did.
confused about what they are.
Yeah, my apologies. I did flip back and forth just with the training for the when I was talking about the master's level person and the bachelor's level person, those are people who supervise the techs. And on the crisis stabilization unit, the direct care staff are the ones who would get the registered behavior tech, which is an additional 40 hours on top of the training that we're talking about, but they're supervised by staff members who have extra training in behavior analysis.
So 2 weeks training to get started.
Yes.
And then I thought I heard you say 40 hours more to get their technician.
Yeah, the registered
certificate.
behavior technician certification, and that's only for the 12 staff that for the behavior stabilization unit that we're in the process of opening. We're anticipating that population will be a lot more aberrant and have a lot more behavioral needs than who we see on the rest of the campus. So we're providing those staff with extra training.
Okay. So after I go through that course, where can I go if I decide I want to go somewhere else? What kind of a certificate do I have to take to another institution?
That is a great question. I've never have seen registered behavior technicians, people looking for them. It's something that we just kind of came across. We were looking for additional training. I'm sure community agencies across the state would like to hire these people. I think they would hire them in at a much lower rate than what is paid here, because we are paying these people a little bit more than our techs because they have the additional training.
And I may be jumping ahead because you've got some information about Larned next. But is it going to be the same? Is the training going to be similar?
For the MHDDTs, Larned, no other hospital has the registered behavior techs. That's just Parsons at this point.
Okay.
But the MHDDT training is very similar at Larned as it is Parsons.
Okay. Well, I'll wait for that additional information. We have a question from Representative Landwehr.
Thank you, Madam Chair. And I want to just get clarification. We're dealing with two different individuals here, correct? An MHDDT and then something else?
Yeah, they're support staff. They're direct support staff. They just have a little additional training, and we're classifying them as client training supervisors, which,
Okay.
but yes.
Okay, and then, so a couple questions on that is, how do you find these individuals? And then what is the rate of pay?
So we're in the process right now of recruiting and you're talking about the registered behavior technician?
The MHDDT and the registered.
Okay. MHDDTs, we at all 4 state hospitals, we are aggressively trying to find techs. The starting pay for MHDDTs at all 4 state hospitals is $16.16 an hour, which is up considerably from years past. The starting rate for the registered behavior techs is about $1 an hour more. And we are having a very difficult time finding those individuals. Out of 12 that's funded for this year, we've only been able to hire 1 so far. We have 3 more that we're interviewing for, but we're having a hard time recruiting people that want to do that.
Okay, so, but where are you looking for the MHDDTs to get them interested in doing the training to become one?
We advertise in local papers, on Indeed, on a website called Handshake, on Facebook, all the normal places that we've called out to different college campuses, different high schools.
All right, thank you.
Uh-huh.
I have a follow-up to that. You talked about the MHDDT and how much they get an hour, and then the regular techs get $1 more. And I don't know where they're at on this list, but what is it that makes or that earns that extra dollar more? What experience or training?
It's that 40 hours that to become the registered behavioral tech.
Okay. So
So it's
the ones that complete the 2-week training get the 16, but if you complete the 40-hour, you're the regular tech or whatever,
yes,
registered tech. I mean,
yes,
is that correct?
yes.
Thank you. Any other questions at this time?
I have a question, Madam Chair.
Okay. Senator Hawk.
Thank you. I wanted to clarify, the people we're looking at may, or is it likely they don't have any previous work experience in the mental health field? Is that correct?
For our MHDDTs, that is a very safe statement. You know, a lot of individuals it's an entry level position. A lot of individuals are straight out of high school, or later on in their career, they've done something else and they want to change. But a lot of individuals that hire into MHDDT positions don't have much experience, if any.
So as you recruit these individuals and interview them, are you able to screen those who may have a desire to work in this area? I only ask this because I had a family member who was very interested in mental health field and got a job in a mental health hospital and decided they did not want to deal with people who had those kinds of issues prior to having that experience. And I just wondered if a lot of these people, perchance after they've gone through the training and have the 5 to 10 hours with actual clients, wash out and decide that's not what they want to do, or do we know that yet? And are there ways to screen people in who may be a better prospect to deal in behavioral health field?
It's a great question. We don't have a formal process to screen individuals. We do try to make sure they go in with their eyes wide open. You know, they're welcome to come in, and we've created books for all the different cottages at Parsons where they can go through and read, here's what a day in life's like. Here are some things that you might encounter, but until you're actually working it, it's impossible to tell. We don't have a whole lot of people that quit after the training, but we have had individuals that have got to the cottage, and even during the staff training, just observations and stuff, and they decide this isn't for me.
Good. Well, I think it's a great idea and I'm glad you're doing it. I just know it takes a special kind of person to actually want to do this kind of work. And I applaud you for looking for the training so that they actually can do a good job and be successful at it. So thanks for your comments. Thank you, Madam Chair.
Mike, who teaches the 40-hour class?
Most of it is online, or a lot of it's online, but I have my director of the behavior stabilization unit is a BCBA, and she does all the hands-on training herself. And the BCBA, once again, is a board certified behavior analysis. That's the one who it takes a master's degree. You have to have a master's degree and then you get additional training to become a BCBA. But she does the lion's share of the training.
To teach it. Yeah.
Yes.
So I'm curious about the curriculum. Is it curriculum that came out of a certain university, or is it just totally designed for the state of Kansas or our hospitals, or just trying to understand that training?
I believe, Senator, it's a nationwide training. I can get you some more information on it.
Okay.
It is not, to my knowledge, it is not specific to Kansas.
Okay. Did you want to ask go ahead. Representative Landwehr.
So then these individuals are being paid while they're being trained
Yes.
at the 1616 or what?
We hire them in at the higher rate.
At the 1616?
No, at the $1 an hour more. They come in at that.
Okay, I'm talking about, okay, we've got two different levels. I'm looking at, first of all, the 2-week training period.
Yep, they come in at 1616.
Okay. And the reason they have to be 18 is because that's what they need to be to work in a hospital, or could they be 17?
They cannot be 17. They have to be at least 18.
Because,
I'm not sure if it's statute or if it's a D of A guideline, but it's just one of the it's just they have to be 18.
okay. So they couldn't even be taking the training until they're 18. So,
Correct.
okay, now that training, that 2 weeks is done in the hospital. The 40 hours additional then is done online.
Yes.
And are they being paid for that 40 hours?
Yes.
All right, thank you.
All training is paid.
All right, I don't see any other questions. You can continue.
Okay, the curriculum at Larned is very similar to what we talked about at Parsons. It is more security focused in many sections. The first 3 things that they do at LSH is an orientation to the 3 separate hospitals, the psychiatric services program. What does that program look like? Who does it serve? The state security program, who does it serve? And the sexual predator treatment program. So that's really the first thing. It's really just an overview of the 3 programs and what it would be like to work there. The next thing is a training called Games Criminals Play. And it's actually from a book, and it focuses on how criminals manipulate staff. 1 second.
Is that supposed to be on slide 5?
What?
Was that on slide 5?
Yes, we're on slide 5.
I don't see where. Oh, there it is. Yeah, it's 2/3 down. Games criminals play. That's
Yeah.
we were looking for that game. It's Christmas time.
Yeah.
Anyway. Okay.
Yeah. It's a complex offender manipulation course is really what it is. Training on fire safety, risk management, which is very similar to what I described at Parsons. Infection control, very similar to what I described at Parsons. At both Parsons and LSH, they also do the employee physicals at that time. Then they go into IT. And at this point is when they go over what we really expect from employees at LSH, how they should conduct themselves working with patients, residents, whoever they may be working with, and then more tours of the specific program that they're going to be assigned to. Then they go into HIPAA training, payroll, benefits, environment of care, which really covers safety and security throughout the hospital, hazmat, emergency management, fire prevention, medical equipment, utility systems. That's all addressed in environment of care, along with workman's comp and staff injuries, what to do if any of that occurs. Patients and residents' right, and then a COS presentation. They also have the same training that I talked about in Parsons, the crisis prevention and nonviolent crisis intervention. At LSH, at Parsons, they do 4 days of training. At LSH, they just do the foundations of crisis prevention and nonviolent crisis prevention intervention. If we could go to the next slide. This is additional training that the security staff get. And the first thing is handle with care, which is an advanced de-escalation and safety hold, safety restraint training. So whenever anyone is getting aggressive or having aberrant behaviors at LSH, they have a very large security staff, and those staff are brought in, and they have the extra training. The security staff also get the CPR and first aid. And then they go through a very lengthy competency demonstration and skills check, which includes, hang on 1 second. And the things that they have to demonstrate during the skills check are hose competency, bunker gear, control center, how to operate all the control centers, engine one competency, their fire engine, handcuff competency, roving competencies, how they go around the perimeters of the hospital, shield training competency, still restraint competency, tomography training and competency, walk through metal detector competency, and then witness statement and evidence competency. They also get, an orientation to the department, and then they go through another orientation, and this one has to be completed within 6 months of hire, and the acronym is STUPID: Successibility, Target, Unaware, Predictability, Ignorant / Intimidation, and Doomed. And once again, that's a complex offender manipulation course. It runs through scenarios on how offenders can manipulate staff. And then they get additional incident command system training. Next slide, Lee, please. The security staff also, we have a partnership with the KDOC, and they get additional training by KDOC on transportation and restraint procedures, cell searches, how to specifically look for contraband, training on chemical agents, such as pepper spray or mace, and then security threat groups, such as gangs. They get specific training on that, and that all occurs within the first 6 months of training for our security staff as well.
Are they taught any self-defense?
They get that in the handle with care training, and it's much more, how do you handle aggressive situations, and there is training. If someone's coming at you, how's the safest way to protect them and yourself? We have ongoing trainings at all 4 state hospitals. CPR and first aid. Our staff have to have at least 4 hours every 2 years, 4-hour recertification. The nonviolent crisis intervention, initially, it's a 2-day training, but then monthly we do booster training with all the staff. And then annually we have to do a 7-year recertification. The handle with care that I was just talking about, that has to be recertified every 2 years. We do annual recertification on trauma-informed care, HIPAA, infection control, what to do if somebody leaves supervision or elopes, guidelines for the pool, cell phone guidelines, visitor guidelines, specific procedures around vehicles, making sure that they're not unattended or left unlocked. We do a reminder every year for our overnight shift specifically about sleeping on duty, and specifically that, that's neglect. Emergency fire responses, cells, policies and procedures around selling things to individuals. And then we have mandatory IT security training every year. This varies a little bit from, this is a taste of what we have at multiple hospitals, but some hospitals, for whatever reason, will throw additional things in that we train our staff on every year.
So, Mike, do you do any personality training, or I don't know if there's another term for that, but to find out if that individual's got the right whatever intuition or whatever that it takes to do this type of job?
We do not. We do keep an eye on individuals. You know, when you spend all of our staff training departments, you know, if they get a pretty good idea for people during that 2 weeks. So if they have somebody that they're concerned about, they always kick that up the ladder saying, hey, I'm really concerned about this person. I'm not sure it's a good fit. And at that point, we'll make sure the supervisor knows to keep an extra eye on them. But as far as testing, no, we do not.
Okay. And do you have a hard time filling this HMHDDT position?
We do. Vacancy rates right now at Parsons, I believe, is about 12%. K&I is 20%. OSH is 46%. And I believe Larned is 60% in their MHDT classes. Now at OSH and LSH, we're supplementing that with agency staff, of course. But yeah, it's difficult. It really is. The raise that was approved a year ago has definitely helped. You know, a couple years ago, we were losing, well, before the raise, we were losing staff to convenience stores, Sonic, just because we weren't, you know, at Parsons and K&I, the rate was $12.24 an hour. But now that we're 16.16, we're no longer losing staff to those individuals.
So if I get my 40-hour certificate and I really like my job and I want to grow either through management or more hands-on activity or more responsibility, what level would I go to? What level would I try to achieve?
So without a degree, it is hard to advance past the registered behavior tech that I told you about. So we have MHDDTs. A step up from that is CTSs, client training supervisors, and a step above that is the registered behavior tech. With a degree, and lots of our staff do go to school while they work here at all the hospitals to advance, and lots of them become social workers, psychologists. We have program coordinators, program directors. A lot of those individuals started here out of high school and worked their way up.
So I completed this certification and I already have a music or business degree. Does that count for anything in that promotion?
Well, it depends what the degree is in, because a lot of times our hands are tied by our like our ICF guidelines. It usually has to be something in a human relations field, like psychology or social work. I have had staff that had business degrees that I wasn't able to promote because they didn't have the right degree to get into one of those other positions. But that's outlined by our different guidelines that we have to follow.
So without a degree, I'm stuck at that level.
It's hard to advance without a degree past.
Let me follow up with, what if I received an associate degree?
If it's an associate's in nursing, you can be a nurse here, but it doesn't qualify you for any of the administrative jobs. Now, I will take that back. We have a handful, Senator McGinn. We have my vocational director started here at Parsons in the late 80s, and she does not have a degree. But we have her in a position, we've classified the position where it doesn't take a degree to be in that. Now, our people who run the cottages by ICF guidelines have to be degreed, but we do have different positions across campus that people can advance into, such as a program consultant, which is higher than the positions we talked about. Does that answer your question?
Yes. We have another
There are
question.
some. There are some.
Okay. Representative Carpenter.
Thank you, Madam Chair. Kind of piggybacking on your questions and your line of questioning. So, Mike, how much of a detriment is that degree situation for you guys?
It does. You know, our program coordinators who run the different units at Parsons is such a key position, and it does tie our hands from time to time on who we can hire in those positions. So I don't personally think a degree makes somebody a good leader or a good manager. And for certain positions at all the hospitals, people have to have degrees to have certain positions. And like I said, that's outlined in our ICF guidelines. So
And who,
it does.
just following up on that, so who is in charge of those guidelines?
CMS. It's statute. Yeah, CMS.
So that's a federal deal to work there,
Yes.
that they have to have a degree to move on from
It's
MHDT.
for just certain positions, such as my program coordinators. There's a lot of different positions that do not, if we can classify them differently, but there are different CMS guidelines for certain positions where they have to have a degree.
Okay, very good. Just one quick follow-up. This Larner deal is a 2-week paid training also.
Yes.
Okay, very good. Thank you.
Representative Whitmore.
Thank you, Madam Chair. You probably answered this and I missed it. So stepping back a little bit for the MHDDT, what is the educational requirement to get hired in for that?
They do not have to have a high school diploma, but they cannot be in high school. The only criteria, well, there's 2 criteria. They can't be in high school. They don't have to graduate, but they can't be in high school, and they have to be at least 18 years old.
So they could have a GED and work in this position. Is that correct?
They could, as long as they're 18, but it's not required.
Okay,
It's not
thank you very
required.
much.
Representative Landwehr.
So this kind of leads down the path that we've been looking at in different areas, is that I think that we need to hear from folks like you and others. What do you see with the requirements that we currently have out there for all these different positions? What do we actually need for requirements? Because we have given the charge to our different licensing and certification agencies to be looking at how they can reduce some of these hours and on some of these degrees, et cetera, in order for us to expedite. So do you have any ideas on that? And if you don't have it today, it's something I think that we would definitely welcome to hear from. Is you're actually doing the work out there, you're seeing what the need is. What is truly the requirement for an individual to do these jobs? Do they really need to have a full degree to do the next step? That's the question.
So I do think all 4 state hospitals try to get creative with the classifications that we put people in. And as long as it's not a CMS requirement that the position has to have a degree, we do have some latitude in that area. So the positions that have to have degrees are program consultants who run an entire unit, which is a natural progression. And it's a bachelor's degree in a human services field, such as psychology, social work, any of, and we try to get creative with that as well. Social workers, of course, have to have degrees. Psychologists have to have degrees. Speech pathologists have to have degrees. Doctors, nurses. But I do think all the hospitals do a nice job of trying to get creative and getting advertising positions that are a promotion that doesn't require a degree. Because we have an awful lot of really good people that work MHDDT as an MHDDT or a CTS that have worked at the hospital for 20, 30 years, and they just cannot go any further. So
I want to dissect that just a little bit more. I think about a nurse, and I think about that they probably took lots of chemistry and biology and all those kinds of things. versus what maybe is needed at the mental health hospital level, which is social and psychological classes or people skills or whatever, whatever they take if they're going into psychology. So, kind of interesting. A nurse can be there, and I don't believe that they take all those classes. I may be wrong. I don't know. We'll have somebody coming up here next that'll educate me, I'm sure. So back to Representative Landwehr's question, what is it that you need? Do you need people more skilled in the psychological areas, or just by the very fact that I have a nursing degree, I qualify for the next step?
Another great question. It differs per hospital. You know, at the IDD hospital, what I really need are people who have training or knowledge in behavior analysis, in working with people with IDD. At the MH hospitals, knowledge of different mental health disorders, maybe the legal system, different statutes, things like that. But it really, outside of what I need them to know, it's really a type of person that I'm looking for. You know, I'm looking for somebody kind and compassionate, and I'm looking for an active learner. I'm looking for somebody who wants to learn. You know, even if you walk in one of these hospitals on day one and you don't have a clue what you're doing, if you want to learn, and you that's the kind of person I'm looking for. And that's at any level. That's at direct care, that's at administration, that's at middle management. It's across the board.
No, very, very good point. I agree. Representative Carpenter.
Thank you, Madam Chair. And I'm not sure this gets into Mike, but it certainly will get into KDADs. Are there any waivers from CMS involving those requirements? And I don't expect them to come to the deal, but I know there are some CMS rules that there are possibilities of waivers of those requirements. And I would just look for answers for that at some point in time.
Okay.
We can definitely check on that, Representative Carpenter.
And your boss is in the room, just in case you didn't see her.
Okay, I did not.
All right. Okay. Anything else for us, Mike?
Well, we do have other positions here that don't require degrees, such as in our engineering or maintenance department. Sometimes those require certifications in plumbing or electrical, but not a master's or bachelor's degree. And our security positions pay higher also, and those don't require a degree. Additional training, as you saw, but not degrees.
Okay. Thank you. Madam Secretary, not to put you on the spot, but since I did see you here, could you just real brief share with us the obstacles that could exist because of CMS and then ICAF guidelines? Just so we can kind of understand the possible obstacles that you have. Thank you for being here, by the way.
Thank you, Madam Chair. Laura Howard, Secretary for KDADS. As Superintendent Dixon said, there just are certain requirements for certain types of facilities. So when he talks about ICFs, these are intermediate care facilities. There are certain federal requirements for certain types of positions. As he spoke, for example, as he mentioned, those who might be over a cottage, things like that. Not dissimilar to the same kinds of requirements that might be faced in a private hospital setting, based on the certification of that facility. We saw some areas during the pandemic, as you all are well aware. Many of you have been very much engaged in this, where some things were made a little bit less stringent, where we were able to have some distinctions that didn't really impact our state hospitals or those ICF requirements. I think, as the superintendent said, we certainly look to find ways where it isn't specifically required by CMS to have a certain role, like the person leading a cottage to have, for example, a particular degree. We certainly look for ways within our classification system to find ways to help people to progress. But again, there are some things we just can't do. I mean, just as you would see in other kinds of healthcare settings, where just as a condition of certification, you have to have certain criteria. And we'd be happy to provide you some details on what that means as it relates to our state hospitals and what those specific roles are, where we just really don't have flexibility.
Oh, appreciate that. I mean, not a 50-page, but like
Right,
you have,
right.
a couple page.
Exactly.
You'd send that to Megan, that'd be great.
That'd be great. Thank you.
Thank you. Yes, Representative Carpenter.
Thank you, Madam Chair. Just piggybacking on that, so are you aware of anything on the federal level? I mean, obviously, every state is in the same situation. Are you aware of anything on the federal level much like we saw with CNAs and that kind of stuff, to address this issue, or are they?
I'm not, with regard to the areas we're talking about today. I mean, I'm happy to talk to our the federal liaison for Kansas in terms of things he might be aware of within Congress. But I think the main things would be more in those areas you've talked about on the the CNA kinds of issues to do with telehealth, those sorts of things, the questions about which of those may be permissions to continue. But in terms of just like basic standards for people in key critical roles in different facility types, I'm not aware of anything as I stand here today.
Very good. Thank you.
Again, thank you.
Thank you.
Appreciate it. Next, we have the overview of educational and training requirements for nurses in Kansas. Carol Moreland, Executive Administrator, Board of Nursing. Welcome to the committee.
Thank you. Carol Moreland, like she said, from the Board of Nursing. Thank you, first of all, for allowing me to come today and share some information. I was requested to provide an overview of educational and training requirements for nurses in Kansas, and I'm more than glad to do that. That's what you have a lot on my written testimony that probably you have in front of you or something along that line. I just want to also add, I had the opportunity over the weekend to listen to the recording of the October 27th meeting. And there were some things there that said there that I believe need some clarification, because I want to make sure that you've got the correct information before you start making decisions. So I'm going to be telling you some stuff today that you're not going to have on that written testimony because I put it in this weekend. I am more than happy to provide it to you if that's something that you would want. There were some concerns raised about if anybody actually regularly reviews the nursing programs, or is there a mechanism in place to know their outcomes, their quality? Okay, there is that. The Kansas Board of Nursing has the authority to prescribe curriculum and standards for the nursing programs and the mental health technician programs, and to provide for surveys of the programs. So all of those educational programs are surveyed on a regular basis. We have a schedule for that. If they're not nationally accredited, they get it every 5 years. If they're nationally accredited, it's usually on whatever the national accreditation is. That might be 8 years, might be 10 years, kind of depends. We also investigate any complaints received about a nursing program. What we also do as far as knowing their outcomes or anything like that, every year they have to submit an annual report to us by June 30th, and that covers that academic year. And it is pretty extensive as far as the data that they have to provide to us. And I'm going to be giving you some of that data today because I think that will help to support that there is quality there. So I thought I would start with licensed mental health technicians. And I also heard in the recording that you asked sometimes, what can they actually do? What is their practice? So you don't have that on your handout, but basically LMHTs practice under the supervision of a physician or a registered nurse. They carry out treatments and medications that have been prescribed. So they can give medications. Sometimes that's a question that we give. They're also involved in the development of treatment plans and therapeutic procedures. Their main focus, though, in their education is working with mental health. And I think that's the key there, because you're going to hear maybe that's a little bit different for nurses. So I have on your handout, they have to, our requirements, they have to have a director of the program. That's all on there. Faculty, their curriculum. I think the main thing to remember here is they do have theory hours and they have clinical hours. Okay, those are not the same. Those are very different. They have to have at least 450 of each of those. The theory classes that they have to have are human growth and development and behavioral science. You will see that they do not have to have anatomy and physiology being a separate course, which is a little bit different for like nursing. Now, I will tell you within their content of their curriculum, they do have some of that stuff built in, but it's just not a separate class that they have to have. And then they have 2 courses that have theory and clinical, and that's your basic nursing concepts, basic nursing care, basically, that they will be providing, and then psychiatric therapeutic treatment. And that again is very specific. They get a lot of education on working with the mental health. Clinical facilities, they have to have those. We also say that they have to be staffed by nursing service independent of student assignments. You'll see that with all of across nursing and everything. So that basically means they cannot be there on clinical and being staffing the unit, included in the staffing mix of the unit. Their existing programs for LMHT cover approximately 9 months. They do have to pass the MHT licensure examination after completion of the program before they can get licensed. That is an examination that is administered by the Board of Nursing. Thing to remember about LMHTs is they're only really utilized in 4 states in the nation. California, Colorado, Arkansas, and Kansas. So there's not a national test, licensure test for them like there is for nursing. So you will see that kind of play into as far as the knowledge of them and stuff like that. They're just not utilized that much across the nation. So they're not quite as, they don't quite know what they are and stuff. Okay, we have one educational program in Kansas. That's at Osawatomie. They have a satellite program at Larned. Osawatomie has had their program up and going since probably about 2014. They graduated their first class in 2015. They usually average about 7 students in a class. Now, to take this, you have to be an employee of that hospital. Okay, so they're not going to let anybody from the outside come in. That's part of their admission criteria, is they do it to staff their own units, is what they do. So I'm telling you that because there's not a consistent, they do this every year. They don't always do this every year. They've had it in 2015, they've graduated in 2017, they've graduated in 2018, 2019, and then 2021. Out of all those years, they've had 35 graduates. They unfortunately do not always have the best pass rate on the licensure exam. Their first time, the last time that they did it was 71%. So, they do have, I think I hit about that. Okay, I just also wanted to let you know that we do have an application that's been received in our agency from someone else who wants to do an LMHT program, and that is KVC in Hayes. That application will go to our board on December 13th and 14th to review it. And then what typically happens, if they've met all of our regulations on paper and everything in this application, then our board approves for us to go out and do a site visit. We do a site visit report, which then comes back to the next meeting. And they review that and everything like that. They are requesting, I believe, to start out with approximately 15 to 20 students, and their projected date is June or July of 2023. Just to let you know, there are 57 LMHTs in Kansas, and that number does typically go down. Okay, LPNs, licensed practical nurses. What can they do? Their tasks and responsibilities are basically what they've been educated on, of course, but it's very supportive and restorative care. They have to be under the direction of an RN or a physician. They can administer medications as prescribed. They can have some limited IV therapy if they've received that content. Not all the PN programs offer the IV therapy. We're seeing more and more who want to take that on, but not everyone can do that. So the educational requirements, they have to have a program administrator also. You know, there was some concerns voiced in the October meeting that we have a high turnover, perhaps, of program directors for the nursing programs in the state. I do not believe that to be the case. A warning sign, and this is national, that might mean that a nursing program is going down the path of having some issues, kind of red flags, if you want to call it that. One of them is to have more than 3 directors within 5 years. Okay, 2 out of our 22 PN programs in Kansas have had more than 3 directors within 5 years. I have been at the Board of Nursing for 12 and a half years, and a lot of our program administrators were in their positions when I started here. So I do not agree that we have a high turnover of program administrators. Faculty, you know, you hear a lot about faculty, and that's very true. You have to have faculty in order to have a nursing program. And the data that, again, I'm sharing with you is data that was on the latest annual report submitted. 62% of the faculty for PN programs are full-time faculty. The curriculum is listed there. They do have to have at least 15 credit hours in nursing courses. That's not overall, that's nursing courses. Now, for the certificate that they would graduate with, the maximum that they can have is 48 credit hours. And that's through KBOR. So what's kind of different between them and the LMHTs? Okay, these are typically done through community colleges or educational institutions where the LMHT programs are not. Again, there's some prereqs that they have to take, like human growth and development, anatomy and physiology, and then they go into the nursing. The LPNs typically have 1 nursing course on caring for mental health, where your LMHTs, that's pretty much most of their curriculum is how to deal with mental health. So your LPNs are not going to have that concentrated content like your LMHTs do. They both can give medications. They both have to work under the direction of an RN or a physician. Clinical resources. The PN programs, part of what they report back to us is how much time they have in direct care. Okay, because there's a lot of belief out there that everything can be switched to simulation. Okay, and then we don't have to worry about the fact that there's not enough clinical sites. That is not the case. I don't know about you, but I wouldn't want someone coming and taking care of me that had graduated that had never actually worked with a real live patient. I think that's something to think about. So our PN programs are averaging about 66% of their hours, and that would be the combination hours of direct care simulation and skills lab. 66% of those are in direct patient care. A warning indicator, or that red flag I was kind of talking to you, is if a program has less than 50% of direct care clinicals. So ours are 66%. So we're over that. They actually average 34% of that time in skills lab. Again, skills lab is where they go in, they practice those skills that they're going to need, and a faculty member is there to assess their competency, and they have to be checked off that they're competent to do that before they go to a clinical and actually start doing it on a real life patient. There's been some discussion, I think, of the faculty to student ratio that we require in the clinical, which is 1 to 10. One faculty cannot have more than 10 students in a clinical. I understand there has been some discussion kind of tossed around that that could be maybe 1 to 15 or something. I will just tell you, raising it to 1 to 15 is not really going to solve the problem, because most of your clinical sites actually put it 1 to 6. And so they really restrict it much more than the Board of Nursing. And actually what is happening now is being restricted down to 1 to 4 in some of the clinical sites. Reason being, they don't really have the staffing that they feel that they probably need. So clinical sites are an issue at times. Simulation, there's been a lot of discussion about simulation, and like I said, could more occur? What we require is that they can have no more than 50% of their total hours for the clinical course to be simulation. So you're probably wondering where the Board of Nursing came up with that idea. There was a national study done by National Council of State Boards of Nursing that looked at different levels. Number one, they had a control group that didn't have any simulation. The next group had 25% simulation. The next group had 50% simulation. They followed those students the whole time that they were in school. They looked at how they did on the licensure exam, and they looked at how prepared they were when they entered practice. They found there was no difference. So that's why the Board of Nursing says that they can have 50%. Our PN programs average 10% in simulation. They have to, of course, pass the NCLEX PN before licensure. You've got there, what their NCLEX pass rates. You also saw, I believe, what's off from our website at the October meeting that you had. There's a lot of things that impact this. It is not just program administrator. It is students themselves. Students kind of tend to sometimes do really, really weird things before they go and take their licensure exam. They have this belief that when they graduate, they need to get married, they need to move, they need to do all this, plus they need to take their licensure exam. Okay, there's too many things going on, so they usually do not pass the first time. Some of them, believe it or not, just take it the first time to see what it's really like. They don't care whether they pass or not. They just want to see what it's like, and then they'll retake it. Well, that actually brings those first-time NCLEX pass rates down for the nursing program. Faculty is a factor, curriculum, clinical experiences, also support resources at the educational institution. How much remediation do they have for their students? Different things like that. Tutoring for their students. So there's a lot of things that impact those. I just want to draw your attention to the average for our PN is 87.2. The national average for PN is 79.6. So Kansas is above that. There's one thing that is not on yours, and I apologize, but another thing that they report to us is the number of qualified applicants that they had to turn away. And the PN programs had to turn away 429 qualified applicants during the last academic year. And that's typically because they don't have enough faculty, they don't have enough clinical sites. Or what we do for the nursing programs is they have approved admissions that have been approved by the board. Now, let me explain how that happens. If the nursing program wants to take up their number of students, they bring that request to the Board of Nursing. The Board of Nursing just asks two things. Give us documentation that you have the faculty to support this, and give us documentation that you have clinical sites to support this. Okay. And then typically they get approved to raise it to whatever they want. So there's just a few of these that it would have put them over their number of approved admissions. All right. We do have a plan in place to follow up with nursing programs that have low pass rates. And so I can promise you that the Board of Nursing is watching that. The first year that they're less than 80%, they get a notice of concern from the board. And they have within 3 months to submit a report to the board in which they've examined their program. They've picked out what are the problems here, and then what is their plan to do that. And they're given a year then to hopefully turn it around. If they still remain less than 80% for 2 consecutive years, then the Board of Nursing goes out and does a site visit to try to see if they can pick up anything that's going on and stuff like that. If they have 3 consecutive years, the Board of Nursing can say to them, you need to quit admitting students until you figure this out. And that has happened. Because it doesn't make any sense to keep admitting students that, the program is not the quality that it should be. Okay, associate degree and baccalaureate degree. Those are 2 levels for RNs. Okay, they both of them practice as RNs. Their practice is the same. So their practice is, they have more biological, physical, behavioral sciences than like the LPNs. So they have more prereqs that they need to take and stuff like that. But then they work with the care of patients, nursing diagnosis of patients, treatment, health teaching of patients that are experiencing changes in the normal health processes. So they have to know what's normal, and then they work with the other ones. They carry out the treatment plan as prescribed for this patient. Okay, of course, it includes medicine and IVs. So education requirements, again, they're the same for ADNs and BSNs. So those are kind of put together there. I will just let you know the ADN programs, 2 out of 20 had more than 3 directors within 5 years. The BSN programs, 2 out of 15 had more than 3 directors in 5 years. Faculty, I've got it all kind of listed there, but just to kind of let you know, 54% of the faculty in the ADN programs are full-time. 48% of the faculty in BSN are full-time. They can also use preceptors, which LPNs cannot. Preceptors are an employee of the clinical agency. So they're being paid by the clinical agency. They're not being paid by the educational institution. And that student may be partnered up with them. Okay, and they kind of work with them that day. That's not too uncommon as they get much closer to graduation that they do that. They also have, of course, theory, clinical, all of that. Their clinical resources, ADN programs, 79% of their clinical hours are spent in direct patient care. So they're over the 50%. And in the skills lab, 15% are in the skills lab. BSN programs, 76% of their hours are in direct patient care, and then 14% are in skills lab. Simulation, ADN programs spend 16% of their clinical hours in simulation. BSN spend 11% in that. Number of qualified applicants, For each of these, for the ADN, it was 614 that they could not, that they had to turn away. Again, pretty much kind of the same. Some of them, it would have put them over their approved admission. Some of them it would not have. The national average first-time pass rates for ADN programs is 78.78. Kansas is 83.86. So we are above that. For BSN programs, they actually turned away 290 qualified applicants that they could not take in. The national average of NCLEX pass rates for BSN graduates is 86. Kansas was 89. So again, we are above that.
Carol, are you about done?
I can be.
In the interest of time, I appreciate all the additional information. I think what I'd like to do is focus on the first page and a half that you presented to us.
Okay.
Because we're here to focus on mental health beds and mental health workers. So I was curious about a few of the comments. I think one had to do with, I want to make sure I understood this, that they could only go into this program if they were already in a hospital or a facility.
LMHTs, yes. Because those programs are taught at Osawatomie with a satellite in Larned. So they only admit their own staff. So they don't admit someone who's not a staff.
So was this a program that was created by those hospitals?
Yes. It's not offered at a community college or an educational institution or anything like that.
And that is at the will of the hospitals?
Well, that's a very good point. That's always been one of our concerns, and that's actually one suggestion I had, that improvements could be made. They get no credit for all the education that they have received if they choose to go on to become an LPN. So there's no progression for them. So it seems like it makes much more sense for this to be associated with a community college or something in which they can get some college course credit. And then hopefully maybe they will want to progress on up into nursing.
Thank you. And then you said you have about 57 in Kansas. You graduate about 7 students. I don't know if that's just Larned or was that just Larned?
That's that program.
Larned.
Yeah, they didn't always have the satellite site at Larned when they first started. It started at Osawatomie, and Osawatomie is the owner, really, of the program.
Okay. And then you said that number's decreasing. So why isn't the number growing? I mean, and so back to, you probably heard me ask Mike about, I'm a MHDDT. I want to go somewhere. I want to keep doing what I'm doing. And it'd be nice if a program like this, which sounds like it is available, if I'm in a hospital setting, I could go into this program. And aside from that certificate, that's a whole nother topic that I'll be addressing. But so if they're not increasing and we need the MD, whatever, or MHDDs, are they leaving because the stress of the occupation, or are they leaving because of retirement?
Majority are retirement. You have to remember the LMHTs, I think regulations start at 1975. So they've actually been in process for a long time, and nothing was done with them. There wasn't even educational programs. So as people were getting older, they're retiring, we got less and less and less. And then all of a sudden there were a need at Osawatomie. And so they approached the board and they said, we want to start a program again. We still had all the regulations and everything like that. So they pulled that up and started it. But you probably have more that retire than they graduate.
And the 450 hours of theoretical instruction and the 400 of clinical, give me just an example of what that theoretical education structure looks like. How do I get that 450?
It's actually done face-to-face. Is that what you mean?
I mean, how I go to class and start earning my hours.
You go to class face to face. They typically have it face to face at Osawatomie and then may stream it to Larned because again, the instructor doesn't have to be right there with them, but they are. Again, it's a lot of the theory about, okay, take for example, basic nursing. Okay, they would go through the process of why we do what we do, and then they move into the skills, and that would be part of the clinical. Does that answer your question? Okay.
Any other questions? Carol? All right. Well, that was very helpful. Did I cut anything off that you wanted to say?
Well, I just had a couple or a few suggestions that might help the marketing, et cetera, to increase the interest in nursing programs. Nursing is not always seen as quite as positive as it was before the last 2.5 years have happened. So because of that, it would be really nice if we could do more marketing about the different levels of nursing, the progression that's available, start with middle school, start with high school, something along that line. We do get some phone calls, but they're not going to be calling us at that age. But we could start getting information. Support the nursing programs however you can so that they can increase their admissions. Okay, and a lot of that is faculty and clinical. And I know you've heard that. You've heard that. Progression plan for LMHTs so that they would receive some credit, which I already talked about. Maybe there can be a bridge program for LMHTs to LPNs because they've got some of the knowledge right there. I think education regarding the importance of LMHTs and how they fit into all of this, because a lot of people have no idea what they even are and where they fit in this. So again, that might appeal to someone out there. And then if we can increase the number of LMHT students that graduate each year, that would help the process. It really would. This next one is very, very simple, not anything. I mean, it's something for us to do, is put information on our website about the scholarship opportunities from KBOR for students interested in nursing. We get a lot of phone calls about scholarships. We don't actually have scholarships ourselves, but I can certainly contact KBOR and get some information to put on our website. And then I think it would be helpful to have a repository of the different acronyms and maybe who is the agency that regulates that. I will tell you before this discussion, I had never heard of MHDTT. I literally hadn't because we didn't do anything with it. And then just, I think a request, anytime there's discussion, maybe about some of this, if there could be a representative from the Board of Nursing, so that we can ensure that you do get the correct information, we would appreciate it. Any other questions or anything?
Good information, Carol, and good suggestions. Back to the thinking about the pipeline and schools. I kind of thought I heard you say that there really isn't any good program. I think about going into a medical type of field. You have to start taking, to me, not impossible, but to me, your interest has to begin at the junior high level.
I would agree.
Because you have to have that foundation before you even know what chemistry is, and the physical anatomy, everything else, biology. So there's nothing out there that you know of.
There really isn't. And one thing that I kind of forgot to tell you is at one point in the last few years, there had been a little discussion between the LMHT and a community college to see if they could kind of partner, so that again, they could start getting some of that college credit. That seemed to kind of fall through. I don't know exactly why, but again, I think that's very important that they get credit for what they've learned and for what they're.
That discussion happened.
I would say, okay, this started up in 2015, maybe 2017, 2018, maybe.
It just didn't go anywhere.
It didn't. It just kind of, I think part of the issue might have been who really had control of the program, because perhaps the community colleges had a little bit different focus on educational principles and stuff like that than the hospital that was doing it. And I think that was part of the problem.
Okay, so it wasn't necessarily a conversation between the um, nursing, um, educational world and the community colleges. It was between the community colleges and a particular hospital that's doing these types of things.
Right, right. Yeah, yeah.
All right. Anything else? Yeah. Okay. Do you know where that discussion happened? In
Actually, probably the most discussion occurred between Barton Community College and Larned. There was a little bit of discussion between Osawatomie and Fort Scott. Now, that wasn't as much in depth, I don't believe, as Barton and Larned.
was local partnerships and didn't really start under the dome here.
Right, right, yeah.
Anything else? Final? Representative Lamb.
So Carol, are you guys taking a look at what else that you can do in changing some of the nursing programs on the requirements of hours and education, et cetera, which is the same charge we've given the BSRB board to bring back so that we can start looking at how we can expedite some of these individuals. Have you done that? Do you plan on doing that to present to the legislature? And if not, can you?
No, we have not. We just redid the regulations and everything for what would be LPNs, ADN, and BSN. And that's where we added simulation and did a few things like that. The LMHT, no, has not been looked at. So that definitely needs to be looked at.
I mean, any of your levels out there. I'm not talking about just specifically with this right here, because we know that we have a workforce shortage. And one of the ways to alleviate that is to figure out how it is that we can perhaps review what our criteria is on the education level to be certified, registered, whatever, licensed, etc. Are we too high? Are we comparable to other states? And we've done some of that over the years. We've done some of our compacts and those types of things. But now it's time to get more into the education. I know I've had some conversations with, Flanders with the Board of Regents that it's probably time for us to look at how do we change, how we're teaching and how do we expedite some of these.
Okay. I will be more than glad to take that to the board in December and let them know the request and see how we can start on that.
Because I think what you're going to see happen is if the boards that we have out there that license all these different professionals, like I said, we've had extensive conversations on BSRB, is that the legislature is going to do it if the boards don't do it. So we're starting to giving them an opportunity to come back to us. And I know that you guys obviously have a willingness to do it because in 2019, we had an APRN bill that had an additional 4,000 hours. And you guys decided they didn't need that education, that they were fine with their 750 to 850 hours. So I know that we can probably expedite some of these others out there. So I'm just strongly suggesting that they come back with it and give it to us, or the legislature will be doing it. Thank you.
Thank you.
All right. Representative Hoffman.
Thank you, Madam Chair. And Representative Landwehr brought up something, and you mentioned the simulation. Now, that's new, that as far as what you have in here, the 50% is new.
Yeah, before we redid the regulations, which just probably went into effect the first part of 2022, we had nothing in our regulations about simulation. That has truly caught up a lot of speed. And of course, as you can imagine, it became a little bit more popular during the pandemic because the clinical sites closed it down, but the nursing programs continued to teach. And so they were able to use simulation. Simulation is great if it's done the correct way and they have the equipment and everything like that. So that is an addition that we've done, is to add the simulation.
Okay, yeah. So you don't know I know that you said that the study showed that up to 50% but you don't know if like 70% is still is viable.
I don't believe there's been any study that's went above 50%.
So no other states going above 50% that you know of.
No, they're all sticking with 50% because of that national study that was
Okay.
done.
All right. Thank you, Madam Chair.
All right, any other questions? All right, thank you, Carol.
Thank you.
Appreciate it. Okay, how about, is 1:30 okay for everybody? Gives everybody enough time. Okay. So come back and be ready to approve the minutes, and we'll start working on our recommendations.
I move adoption of the amendment, a minute. Or you want to do it later? Okay.
All right, we'll call the meeting back to order. And at this time, do I have a motion from Representative Landwehr?
Motion to adopt, to approve our minutes from our last meeting.
Second by Representative Moore. Discussion on the minutes? Seeing none, all in favor say aye. Opposed, no. Motion carries. Yeah, I know. There we go. He didn't want you to see the bars. Okay.
They let him out for the day.
I have, just so you know, the chair has 3 items that I will be speaking to. And so if you have other items you want to add in this recommendation, please let me know as we move forward. But we were sanctioned to have this interim because of beds in South Central Kansas / close to Sedgwick County, if not in Sedgwick County. And listening to the testimony that we heard from Sedgwick County and the mental health hospital that a private company is trying to manage the load in that area, and the fact that a high percent of people from Sedgwick County and the surrounding counties take up a good portion of the population at both Osawatomie and Larned Hospital. I'm going to recommend, and this is all up for discussion, this is just to get the ball started and we can talk about it, okay? I'm going to recommend that we put up to 50 state beds, state institutional beds in the Sedgwick County area. So that will be my recommendation. So now we can talk about it. Representative Langworth.
One of the things, Madam Chair, that as I've looked at this process over the last couple of years, and we've been talking about beds, and I would like us to, I think starting with 50, because we're going to struggle trying to staff 50 beds, is whatever we do, I want to make sure that there's room for expansion for further beds, because I think down the road we're going to need a minimum of 100 beds. So I kind of want that clarified a little bit, that we start with the 50, but wherever it's at, it has to have room for expansion.
So that could mean just even bare ground, just the ability to grow adjacent to that, wherever the facility is located.
Yes. Or, if an existing building gets found and let's say it's got 200 beds, okay, fine. But we're only going to start out with the 50 of what we can staff, and we have to be realistic on that. Because one of the things that's going to be really difficult to do is for a hospital to start up and make sure that they're not robbing from Peter to pay Paul, which means they're robbing from our other hospitals or our CMHCs or, that type of stuff to staff them. But I don't want us to shortchange ourselves and have to come back to the legislature and say, oh, now we got to build another building. No. We make room for that plan. And if we don't need the beds, then we don't need the beds later on down the road.
Representative Waymaster.
All right, thank you, Madam Chair. And I just want to echo what Representative Landwehr said. I think it was one thing that was paramount when we were talking about, obviously there is a dire need for a state hospital in the South Central area of the state. But that was one thing that was expressed. And I agree with Representative Landwehr that I think we need to be pragmatic about it and also look into the future. Obviously start out with 50 beds, but then we need to be aware that there's probably going to be an expansion of beds in the future. And so that was exactly what I was going to say with what Representative Landwehr said.
Keep in mind, my next one is to talk about workforce. So the two come together. Yes, Representative Carter.
Thank you, Madam Chair. And I think along with that, what was the location going to be? I mean, was there a perimeter on the location as far as, within 20 miles of Wichita or?
I believe the proviso says the Sedgwick County area. So much will depend on whether or not they get the Spark money. will be one. And if they get the Spark money, it'll clearly be in Sedgwick County's hands to decide where. If that doesn't happen, then the governor could make a decision whether or not she wants to put money in to have a hospital if the Spark money doesn't get there.
Yeah, and I think just from my own point of view, and I agree with Representative Landwehr and Representative Waymaster on the other thing. My concern is if we find a building and it's within a reasonable amount of distance, I'm not sure it's preferable, but we need to look at that. I don't know what the expenses versus a remodel versus building from scratch would be, but the distance within, say, 20 miles is, I think, not much.
And I think that's where it gets into, if they move forward, architects will have to come in. We know there's a hospital up in Harvey County as a possibility. We know there's facilities in the Newton area. And if you think about Newton, I don't think Sheriff Easter will mind running up the highway 20 minutes versus what he's been having to do. So it is Sedgwick County area. And again, the location most likely won't be in our hands, but if the governor puts it in her budget, then I suppose we'll be having a discussion about that. Representative Waymaster.
Going, back to the point and just having it decided where the location is going to be is going to be up to obviously the legislature to decide. But there were 5 of us on the legislative budget committee meeting on Tuesday where we got the profile for the next 5 years. Now I would probably gather to say that for the next 5 years, the way the profile looks is a little rosy. I think it's not going to be as much of an ending surplus in 2027 as was projected on that profile. So I think we need to take the opportunity now in fiscal year either 2023 or in 2024 to administer the money for a state hospital, because we may not have that money to start it up in the future. Now, the workforce costs, we're going to have those. It's going to be an ongoing cost. But as far as the initial purchase of a building and renovation, we need to allocate that in probably fiscal year 2024. And I think that needs to be a very strong recommendation from this committee that if we're going to do it, we do it in the next fiscal year.
And we do have the money that we put in this year that will help with facilitating the process. So. You what?
He hindered the process.
Oh, representatives.
Well, and I think, Representative Waymaster brings up a very good point. I think, maybe we want to set a time certain that this decision needs to get made, because I also think that we have some people that may be dragging their feet for varying reasons, and I don't care what they are, but within the next 2 years, this has to be done. I don't think we let it drag.
This next session.
Well, that would be my preference, because it's going to take at least a year, if not longer than that, to actually get it physically up and running and working on the workforce and yada, 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 yada. So
I'm not saying cut the ribbon, but
right,
we need to be started on it.
Right.
Go on.
Yeah, just don't let them drag their feet. So I think we put a year out there, and that's what they've got. So I would add that to your idea.
Well, and that's what I meant by hindering the process, because there was basically no, and there still isn't, I think, a plan yet from the concerned parties, and they've got to get off center on this. And that's why I tried to make them get off center by postponing the 15 million. And they've still got to get off center. We still haven't seen anything.
And I think we're helping them. We're guiding them, so to speak. Yes. Senator Billinger.
Thank you, Madam Chairman. Anyone have any type figures on what a 50-bed unit facility would run? Anyone have any kind of ballpark?
The proposal is up to 50 beds. And Lee, it's been a long time since May. The 25 million was the estimate to pay for. Go ahead and say who you are.
Lee Keck with KDADS. What was in the governor's budget proposal last year was the 15 million was for the ongoing cost to run a 50-bed facility. And then in the budget proviso, it got transferred to this first year. It could be used for startup costs, whether that be renovation or establishing a new facility. I think the original Sedgwick County request to the Spark Committee was 40 million to do, whether that's acquiring land or renovation of a current building, but that initial building process for the facility. But what 15 million is what started as the governor's budget proposal for running a 50-bed facility. Yeah.
And it was the other money that Sedgwick County requested.
Correct. Yes.
So the Sedgwick County requested 40 million? Is that what you just said? Okay. And so the money we put in was for operation, but it can be used for.
It can be used to help them get started. Just like maybe you need architectural
Sure.
renderings or something.
So the Sedgwick County commissioners, were they talking similar size, or was they talking smaller or larger? Or?
Similar size.
So 50 beds, and they felt like 40 million. And how much are they asking from Spark? Oh, so they're asking all of it from Spark. Okay, that's why I just wanted to kind of seeing where we were, cost wise. Thank you.
When it comes down to it, I mean, if 40 million pays for 50, or if it only pays for 30, that's probably how the ball rolls.
Sure, thank you.
Thank you, Madam Chair. When will we know the outcome of the Spark request?
What, am I not close enough to the mic? Okay, sorry. Who knows that? Let's see. Who's got their crystal ball? Do you, Kyle?
Slept in a Holiday Inn last night. No. Is 65, is 40 realistic? Because I think the lab is 65, isn't it? The new lab we're building. And I would think it would be comparable. So, we were talking, so I might have missed if that's what you asked, if 65, or I keep going back to 65, if 40 million is realistic, really, are we needing to pump that up, or are we going to be asking for a specific amount, or just saying we're going to fund it?
I mean, we have to stay within the guardrails, and excuse me, Gary, I keep going back and forth. And this is going to State Finance Council, so they can adjust anything we do. And if we do find out next year, and that's what I felt like I heard in next year's budget, once we have more information, we can make that adjustment. And back to the Spark money. Does staff know when Spark is meeting? Does anybody know? Is anybody online? Could you please call in?
It would sure be nice to know that. It helps us get down the road a lot farther with our decision making.
Well, if it happens by the end of the year, there's another proposal in here so that we'll be able to make some adjustments if needed. Representative Waymaster?
Well, and what I would say in regards to the Spark money, I think we'd make this a recommendation to the legislature in the intent that we hope the Spark money is going to be approved. However, if it is not, because as of yet, I haven't heard a date of when the executive committee is going to meet, and then it's going to go to the State Finance Council. And then if we get into the legislative process, who knows what might happen to the remaining funds from ARPA. So if it's not approved by Spark, then we need to allocate it from the state general fund. But we can always make those adjustments later if the Spark money is not approved or is.
Representative Waymaster, so would there be something then preventing us from allocating it from Sparks ourselves? If we got down to that.
Actually, if you look at last year, no.
Okay.
We did it last year.
I'm just saying worst case scenario, if it doesn't move in, a timely manner, then rather than the SGF piece, because I think your point earlier is, we're sitting out there with these rosy balances because of what a one-time
Exactly.
money. And so building a facility is a one-time money thing. The ongoing,
Precisely.
we're taking into that as well. So
Yeah.
that's what
But that's what we did. We allocated ARPA funds last year in the budget. So that wouldn't prevent us from doing that again.
yeah. So I say it all stays on that we make sure that everyone understands our intent is the spark money on this and not necessarily SGF.
So are you getting ready to talk?
Well,
You just want that mic.
no, I'm getting ready to talk. I mean, that brings up, I really think somehow we need to, as like Representative Carpenter was saying, we need to get those that are wanting to do this in Sedgwick County, get them off of center and give them movement. Because if we're going to put in an amount, even if we're going to use the spark money, we need to know the amount of money that we're going to put in. And I mean, I think 40 is pretty rosy. I don't think 40 will pay for it, but so I think we really need to have an idea from someone how much it's going to actually cost us.
And I may not be accurate, but that's how I envision that money that went in from the state, KDADs or whatever. Those are dollars that could start that process while we're in session, to get those numbers that we need to have. Okay. All right. So I'm going to let staff later read everything back, but the proposal is that Sedgwick County area will receive up to 50 state institutional beds. The location that is chosen must have the ability for expansion.
Do we put the mention of our spark money in this, with this motion you're making here, Madam Chair?
I don't think it would hurt.
Let's do that.
Could put with the intent or hope that the spark money will be received. Yes. Senator Bellinger.
Thank you, Madam Chair. If we're going to encourage them to fund it, I'm good with that. I think if you say in there, if you don't, we're going to fund it some other way, they're going to go, well, they've already got it figured out. Thank you.
That crossed my mind too. So whoever's drafting this, make sure you get that right. Yeah. Okay. So the next item that I would like to talk about is the workforce pipeline. As you know, we started our first meeting talking about state institution beds in Sedgwick County area. And our conversation, I believe, for at least the next 2.5 meetings had to do with workforce, if not 3 meetings. And the workforce, as we all know, and we've seen the numbers, we've received the data. It's been a struggle at our other 2 institutional hospitals finding employees. We know that these beds will be in a very populated area, so the hope is that we're not going to not be able to hire employees. But the bigger picture across the state has to do with how do we get our next generation interested in the proper course curriculum or exposed to serving a mental health community. And in order to do that, I believe it needs to start at the junior high level. And then make sure they're taking appropriate courses in high school. But that's if they're going to go on some of that. That's if they're going to go to a 4-year education. But what we also learned, and particularly we learned today, that there is a need for mental health DD technicians. Wrote that down somewhere here. Yeah, but vacancy rate was 12, I think was Parsons, or 20. And then I got those first 2 I didn't get, but Osawatomie was 46 vacancies and 60 vacancies in Larned. 60%, thank you. So that tells me that there is a need for that level of skill. And what we also learned about that level of skill, once those individuals take the 2-week course and then later take the 40 hours, I believe it was, to become the MHDDT, and they want to continue their career in that facility or another facility, there's really no hard certificate, and there's no way for them to go to the next level without some kind of public school or private college academia to continue to go to a higher level. So what I'm going to propose with this, just when you guys thought we were going to be done today, we will with our recommendations. But what I would like for us to do for our final meeting that is available to us, we had the nursing community in here. We had the hospital community, both the private hospitals and our state hospital community. We had community colleges, 4-year colleges. What I would propose is that that for our last meeting that we will have a Zoom meeting and bring the proper entities from each of those areas along with an agenda that all of you will see ahead of time, and have this conversation with them so that before we go to the legislature, we're not all guessing and we all have a different vision about a workforce pipeline in this area. So we have the key players across the state who makes these educational decisions. But in addition to the educational criteria, we need to have a discussion too about how do people get from a certification that's specific to a hospital to some kind of hours earned at a 2-year college or something like that, a technical school. So we may be looking at a new level. We may be looking at figuring out how to get the MHDDTs up to the LMHTs, licensed mental health technicians, but making sure that people have a certificate or a diploma or something so that they can move up into the system. And in addition to that, should be conversations about scholarships, internships, and then this whole licensing. So those are just my introductory comments. I'm open to your suggestions. I'm recommending a Zoom because we're all busy at the end of the year. And I thought if we could with the help of staff, get the players together, and then get a Zoom on the calendar, then we can have this conversation together. Representative Carter.
Thank you, Madam Chair. And I don't disagree with one thing that you've said. I think what I've seen over the years is the devil really is in the implementation. You know, we can have this great piece of paper and hand that to people and put it on a shelf, do whatever. But I really think that what we should think about doing is going out for an RFP to a university or some organization. I don't necessarily care who it is, to make sure and to also to track what we're doing, because we can talk about these scholarships all day long and they're good, but are we going to make sure that they're happening? And are we going to be able to track that in next year or the year after that? But this pipeline, I agree, is 100% very important. I think that we're way behind the 8 ball getting these started because at the very least they're 2 years out. And even more than that, 10 years for junior high kids and to perk these people's interest, these kids' interest, you know, very young. But it worries me that we don't have something to implement that to make sure that our recommendations are actually being used in the community colleges or in the colleges or by the hospitals, by anybody that's going to start this process, and that we have no way of measuring. It's just a shotgun approach. You talk about it, throw it out there, maybe throw some money with it, and then we drive on. Well, I think we really need to look at some kind of process for the implementation of this program.
I think that's a great point, and we've just found out at the last meeting, the psychiatric program that I ask about year after year hasn't grown, hasn't gone anywhere. And, first it was COVID, and now, it's been out there for a while and it's not going anywhere. So totally agree. Representative Landwehr.
Well, and don't forget to add the BSRB to this, because the whole idea is not just these ones that we've talked about the last couple of meetings, that don't have certificates or degrees or registrations or whatever with them, but it's looking at all of the programs that we have out there in the education circle. Are we requiring too many hours? Are we requiring the right hours that they actually need to go out there and start doing the job? Then I think we start looking at, okay, how do we design something? And you and I've had this discussion, and I know you've had it with others, is like what we've done for our physicians. If you're going to work in underserved areas, then let's help step up and, we'll pay for some of your education on this. Our technical colleges could play a big part in this, which makes it a more economical thing. And we have the HOPE Act that sits out there. So this could be another part of it. I think that when Blake Flanders appeared before us, he's got an interest in, okay, are we doing what we need to do for today? Or are we still doing what we did for yesterday? So I like this idea, but we need the experts to come to the table. And I reiterated this in the CanCare Oversight Committee, and I'll reiterate it here, that if the folks that are supposed to be the professionals that know this better than us, because this isn't my area of in my private life, then I think the legislature is going to have to do it and figure out what we need, and then let people come and tell us why we can't do it that way. Because we can't sit around and keep studying it and study it and make it happen. I think that our physicians can bring us their ideas. We heard from Mr. Dixon with the state hospitals. Well, okay, what do you need? Well, what I heard him tell me is, I have a qualified person, but because they don't have a degree, I've got them doing this job. I just classified them different. So how do we fix those things? So he needs to bring those to us. I think our hospitals can also bring us something. What do they see within their facilities that would be some kind of an associate's type of a degree?
Senator Hawk.
I'm probably repeating most of what I heard, but I like the idea. I just want to make sure that we have the stakeholders that can actually make this happen. And you mentioned Blake, so I think KBOR needs to be on there. Mentioned tech colleges. I don't know if all of them have a nursing program. It seems like we need at least one of the higher ed institutions. I know Emporia State, I think, has a nursing program, and I'm not sure which others do. And then we have private colleges. So I worry about it getting so big that we can get lost in the detail. But I think it's important to have the stakeholders that could actually not only tell us what the needs are, but we could hold them accountable to figure out the roadblocks and to get the certification and the programs there. So I think we're clearly on the right track, and I appreciate the conversation I've heard so far.
Representative Wolfmore.
Thank you, Madam Chair. And just to go a step farther, it would be nice if when they do come before us, if they sort of know what they're looking for, what we're looking for, if they come with ideas that we can maybe react to, things that are doable to help with the pipeline, or maybe in the case of the community colleges, ways they see we could extend the pathways. So it'd be great if they came with some ideas rather than just answer our questions.
And I think we'll have staff draft something for them so that they stay on track as to what we are looking for.
Thank you.
Thank you, Madam Chair. And you mentioned earlier about the program we started for the engineers at the colleges, and maybe that's some program we ought to mention also, that maybe we should look at a bill or something to come up with another plan like that engineering, because that's been very successful.
Well, and when we had the conferees earlier today, I mean, they hit right on, in some areas, they're putting together private-public partnerships. And that's what they did with engineering, and I don't know why we couldn't figure out how to do that here as well.
So I thought that's a good idea when you brought it up.
Anything else? Yes, Senator Hawk?
In addition to the engineering, I think we had a vet med program that might be an interesting model to look at too, that I think is similar but slightly different.
Okay. So, make sure staff that you have in the point that Representative Carpenter made. I think that's very key. If we don't want to be sitting here 5 years from now having the same conversation. We need, and I don't know how we might ask the state finance council this, but I mean, we need to somehow request somebody to be able to evaluate and track. You want to add to that since that was your idea?
I think that maybe, you know, I mean, we have some very good universities around, and there may be an opportunity for them to, if we could put in an RFP of what we want, to gather that information and continue to, I mean, it's going to cost money. There's no doubt about it. But that's what I had envisioned. I know Wichita State's done some workforce stuff, you know, in that kind of stuff. And this would be a little bit more than that, but it could be written up in the RFP, but it would be open to all the state colleges or, you know, but I just envisioned it being more than just, well, we're doing this, but what are we doing and how is it working? And that's how it grows. We concentrate on the things that are working and quit doing the things that aren't.
All right. And to add to that, and we'll do this one before we leave, that we'll figure out who the entities need to be for this final conversation meeting, and we'll figure out a date that works for all of us. So, okay, that's all I have on the mental health side. We did have the hospitals testify, $5 million for 5 years to help them have somebody that watches the mental health patients that come in their ERs and they're overloaded, and they need a little bit of relief until, you know, maybe these beds get built and we start having some kind of relief, or maybe we stumble on some other kind of program that's very helpful to our state and it's not as big of a problem. But does anybody want to speak to that? Say away, Master.
Thank you, Madam Chair. And actually, I would agree with you. I don't know if $5 million is the right answer, but that's what the Kansas Hospital Association approached us with. The only thing that I would probably preface is that we do a 2-year pilot and make that be a recommendation as opposed to a 5, and see exactly how it is administered through all the hospitals throughout the state. I mean, obviously, as we heard from the Kansas Hospital Association, we've also heard from law enforcement that they're dealing with mental health patients and they don't have the capabilities or the knowledge to handle those individuals. So obviously, I think in our hospitals, and actually, I wish we could do something for our county jails as well. And maybe in conversations, we'll come up with something. But right now, for our hospitals, I think they are in dire need of somebody there with the capacity and the knowledge to watch that mental health patient that is in their hospital, in their emergency rooms. But I would just suggest that we limit it to a 2-year program. Hopefully, then that state hospital will be open in South Central Kansas or Sedgwick County, and then that'll alleviate some of the pressure that is affecting our hospitals now.
I would agree. And we've gone through so much change as a state and a country in the last 3 to 4 years. We don't know what next 2 years is going to look like. So maybe something else, it should be something else in 2 years. And would you have them report back to the budget every year or after that 2 years is finished?
No, I would probably suggest that they report back to the social services budget committees in both chambers every year, and we just see what the status is. So we make sure that we're following up on it on an annual basis, and probably more than that, actually. I would probably, if I could make a suggestion, I'd probably say that we have it discussed in interim committees. We have it discussed as a topic in the committee, but yeah, we definitely need to have some type of an update to see how the program is being administered.
Representative Landwehr.
Well, and I think if we put the responsibility on them to come back and show us what the proof is that this program is working and figure out what that report looks like so that they can come in, how do we measure it? What are the things that we need to be measured? So I think between them and legislators, we can figure that out. And rather than create another committee, you could have that reported to not only the social service, but then also your CanCare oversight. Because CanCare kind of ends up, taking a whole lot from a budget perspective. And then you wouldn't have to have a dedicated interim just to look at that piece, because I don't think it's big enough out on its own. No, but you say, okay, it would have CanCare looked at, so it'd have to be looked at.
Well, and it would have more legislators hear what's happening in our ERs. So it would educate our body as well. Representative Hoffman?
Isn't that mostly a reimbursable through CanCare is what that would be through?
I think it's a code. Was it
Is a code?
Tara, why don't you come up and explain to us about how that would be distributed?
Yes, Madam Chair, I'm Tara Mays with the Kansas Hospital Association. Thank you so much for the question. I think your question is, isn't this a reimbursable expense through the CanCare program? Would it be? So the actual answer to that is this would not be CanCare patients. So these patients are not CanCare patients. So what we're asking for is reimbursement program outside of the CanCare. There is a code for reimbursement for one type of patient treatment, but what these patients are getting are not really treatment, it's observation. So that's a little bit different. So that's why we're asking for this, and we would be comfortable if there needed to be some language in there that just says not including those that are reimbursed by CanCare. So just wanted to answer that. Happy to answer other questions. Thank you, Madam Chair.
Well, and by me mentioning CanCare, it probably kind of confused. I'm just looking at a major committee that looks at all of this healthcare stuff could take a look at it, but it has nothing to do with CanCare patient. Like she said, I don't believe there is any code out there that we could bill. So this would be an SGF expense ongoing.
Representative Carpenter.
Thank you, Madam Chair. And my question again is for Hospital Association. So how did you come up with this $5 million figure?
So it is an estimate. And what we used as we worked with the law enforcement community and KDADs to look at the times that are currently out there that people are awaiting admission into the state hospitals, and then what we know we're holding at the hospital level. And so we did a survey of all of our hospitals that ended up holding those patients and tried to come up with what we thought was probably a reasonable estimation. But I will tell you, it's an estimate.
And so it was based on what? 5,000 hours is it based on an hourly rate?
Yeah, it's based on
an hour.
And those patients that are awaiting admission on hourly rate, we kind of took it back from that and said, okay, so what's a day rate? Yeah. That's what it's based on.
So you have some figures probably, I mean, it's a guesstimate, but what were you figuring for your hourly rate?
Ed, do you remember? I can go back and find that information.
Oh, just curious, how you arrived at that figure.
Yeah. So I can go back and find that figure for you. I don't have it off the top of my head today.
Okay, very good. Thank you, Madam Chair.
Yes, Representative Wolfmore.
Thank you. That stimulated another question for Tara, if you don't mind.
You keep running away from that microphone. You should
I'm
sit down behind you.
very supportive of this idea. How would that be distributed across hospitals? I wonder. That would be the.
So it would be a reimbursement program the way we have envisioned it. So you would have to submit actual documentation of that particular patient and submit documentation that they wouldn't be eligible under any of those other programs that we just mentioned.
Makes sense. Thank you. Thank you, Madam Chair.
And I think the reporting would be good too. Just, is it too much or is it not enough? So it'll be interesting to hear what the first year looks like. Representative Hoffman.
But who would be the reimbursing it?
State.
Well, I know the state,
It's a
but it's going to have to come from somewhere. I mean, an agency's going to have to be KDADS.
That sticker has your name on it.
Yeah, sorry. So the way that we've envisioned it is that it would be a reimbursable program through KDADS. Since they're the ones that kind of keep track of all of those inpatient times and those kind of holds, that made sense to us, but we're open to other options.
We don't want you. Okay. Never mind. No. Anything else on this topic? Okay, those are the basic topics that I was thinking about as I was getting ready for this meeting. Is there anything else? Yes, Representative Carpenter.
Thank you, Madam Chair. Well, this is something you won't be surprised at me talking about. Privatization of this home, this facility. I think that we should actively look for a company to contract the operation of this facility. We don't do a very good job. We don't have a good track record whatsoever of running state hospitals. And I don't think we need another one to operate and worry about the workforce and all those issues. And so I would just strongly recommend that the committee look at privatization of this hospital, contracting with another provider. Somebody.
So it would be an option. Private versus public, take a look at both. Let's see what's best for our citizens. Anything else? Any other topics? Yes, Representative Waymaster.
And I'm going to this is probably going to generate a lot of questions. There are two items actually in regards to, the first would be, and I'm sure KDADS, KDHE, ECF, all of the entities involved do look at this. But when I was at the Medicaid Leadership Academy in September, I do think there are some waivers out there that we are not utilizing with CMS or with Medicaid. Because we had a discussion about that, and I was going to try to pull up the agenda because everything was done online at that meeting, and my battery went dead on my laptop. But it's fine. I think I remember kind of what the conversation was. Anyways, we need to make sure that we're actively utilizing every waiver that we possibly can in reimbursement for Medicaid dollars, especially in regards to mental health. That can be for either the facilities, or it can be, back for reimbursements for care that was given to a mental health patient. I just think we just make sure that we are looking at every single waiver that we possibly can in regards to whatever could be reimbursed for Medicaid. So that's the first. The second is we actually had some roundtable discussions when we were there, And some states, as we talked about earlier this morning, the state of Michigan seems like they have been doing some research in regards to not only mental health, but other social needs in the state of Michigan. And one of those was that the state of Michigan has created, in regards to having it be reimbursed by Medicaid and using a waiver, particular apps that the state is utilizing for certain needs. And I think that's one thing that we need to start looking at as a state. We're an emerging technology. We need to start looking at different ways of accessing people, because the way people access information is different than it was 5-10 years ago. And so one of the printouts that they did give us when we were there had to be with needs, awareness, and usage. And in all three of those categories, mental health was at the top of Michiganians looking at or utilizing an app for services, where they could get help, where they could get needs. And in fact, in needs itself, mental health was number 3. It was number 5 in awareness, and it was also number 6 in usage. So I think we need to be looking at new ways of reaching out to those that are needing and asking for help.
Very good. I like the app idea. I think that can be done internally by our agencies. As Lee appreciates hearing that. But I think that's a great idea. Representative Landwehr.
Well, there are some apps that are out there. There's also with the 988 system, and with our CCBHCs, we've got some states. I know Oklahoma is doing it, where like a law enforcement carries tablets, so that if they get into a situation and they need someone now to help with this individual, they have that. They can go live with that person, basically with a Zoom call and stuff. So I think, that's definitely on path with where we're headed. The only thing I would say on the waiver codes that you're talking about, we're always very cautious with those, because they all have a dollar figure that gets attached to them, and then they get blown up. And it's one of the reasons that, and Representative Carpenter can chirp in here, because he's responsible for that particular budget at this time, is that we make sure that we can maintain and control the ones that we do have, and always be able to fund those as we go. And that's why we're very careful about how we open up those codes, but it's always something worth looking at. So I appreciate you bringing that. Going back to the workforce pipeline, would the committee be willing to put something in there that we also look at possible wage disparities? Just to make sure things are lined up. Go ahead.
Thank you, Madam Chairman. Yeah, I think the expert this morning, and I've heard it over and over again when I've visited mental health institutions, facilities, the wage is definitely something that makes a difference when you're trying to retain your staff or hire your staff. And probably the best way to pair that is what she also mentioned, was improving Medicaid reimbursement for behavioral health, so that they're on par. So if you, I'm not talking about Medicaid expansion. I know you think I am. But if more money's actually coming in because we're getting better reimbursement, certainly they're going to be able to pay people better, and that does help with retention. Thank you, Madam
Chair. He was first. Representative Carpenter.
Thank you, Madam Chair. And I agree. I think the other hospitals, as you heard Mike talk about, had benefited immensely from the wage increases. I think that because there are other reasons why Larned has not benefited from that. I think we just need to realize that there's a location issue there. And even if we paid $25 an hour, I still don't believe that we could move the needle to attract people to Larned. And I'm not saying anything being critical of Larned. I'm just saying that's reality. And we've tried that. They're making the same pay as the others, which we've had success at. Larned is another animal. And if we could do it, I'd like to try to increase that wage just so I can prove the point that it's not about wages at Larned.
Representative Landwehr.
Well, and something else that Representative Wolf Moore made me think of as she was talking, and she brought this up earlier when we had our conferees, is not only do we need to have these organizations we talked about, whether it's the Regents, the Board of Nursing, BSRB, or whomever, is to also look at any barriers that are created out there for people that have been out of the workforce for a while and then decide they want to come back. You know, what barriers have we artificially set up out there that keeps them from being able to come back? Because maybe it's too much CE time, maybe it's, you know, I don't know what all's out there. Again, we need the experts at the table and the stakeholders, as Senator Hawk talked about. So that would be another piece, is to bring that CE piece out there so that we don't forget it. Yeah.
All right, well, while staff is tidying up their, figuring out what we said, everybody go to their calendars while we have them. And I'm thinking, you think we could get this meeting done in 1 hour and 15 minutes? I think you hang on much longer than that. And if we had a very concise agenda, or do you want to? Maybe we should just put 2 hours on our calendar for now, and then we'll see what that agenda looks like. So obviously we're looking at December. The 21st is free. 19 is free. Okay. What about 21st? For Zoom. Senator Hawk, 21st for Zoom.
You can tell I like Zoom or WebEx. Teams. No, not Teams. Yeah. Yes, that works for me.
All right, very good. Zoom for all. 10 o'clock in the morning, okay? Staff, are you okay with that? We should ask you. What? 21st. I don't know if you're gonna be out of town for training again. You get that done. Okay. Are you all trained up and ready to go? Okay. Scott? 21st. You're invited. Okay, that was simple. Good. All right. Who is going to summarize what you think we said? All of them. All right. Yeah, that'd be good. Yeah, you need a mic. Okay.
The first recommendation I have is open 50 additional state institutional beds in the Sedgwick County regional area in a location that has room for expansion, with further recommendations that the process begin within the next calendar year and be funded with the $40 million in ARPA funds that was requested by Sedgwick County for this project.
And I would just add up to 50, because back to what Senator Bellinger said, you know, if it turns out we can only afford 40, And then back to Representative Landwehr's comment. Do you want to express that? The location of the beds must have the ability for expansion.
Yeah, I currently
Say that,
have
I missed it.
Sedgwick County regional area in a location that has room for expansion.
Not take into consideration the 15 million that's already out there. We just need to do the 40.
I guess I'll.
Because I thought the
stop.
15 was part of helping get things started.
Yes. So state finance council ultimately can make the decision, or did we make it in the budget? 15 million.
The 15 million is subject to state finance council approval. So this committee's recommendations and your report will go to state finance council, and then that $15 million through the end of this fiscal year is up to them.
So would you like to add something about because the 15 million, we're not going to be operating beds first year, is there to help facilitate or what?
I guess that's where I'm somewhat confused because I was thinking that there was a need for the 15 million as they started the RFP process or something. I mean, I've never done a project like this, so I don't know how that works.
That was my thinking.
So they would need the 15 million.
KDADs, that it was flexible, could be used to help start the RFP process.
Yeah, and I just figured that, the finance council would, and between the finance council and then the county people, they'd figure out what is that mechanism as if it was their own money. And how would that have to be allocated? When would it be allocated? Do they need $5 million to show someone that they're serious about doing this? I don't know how that works. And that's a weak spot for me.
And I want to make sure that it's not just a given that it's going to go to whatever Sedgwick County wants. It
Right.
needs to be KDAD's decision.
Agreed upon, yes.
Yeah, that, okay, we understand you need the state's decision. We understand what you need in order to get this process started.
So the county has to work with the
State. Okay.
Does it make sense to add a recommendation before that just we recommend that the state finance council approve $15 million allocated for this project?
The 15 million that was already in the budget for this project.
as deemed necessary, I guess, between the state and the county.
As
Between now and
necessary
then.
to start the process.
Yeah, the RFP process.
Yeah.
Because I think there's an expense associated with starting a whole bid process of laying out what you want, how you want to do it, where you want to. I mean, there's expenses that go with that. And my understanding was that's what that 15 million was for. It wasn't for operations of a facility. It was whatever you have to do to initiate a project like this. I've never built a building of this size, so. Huh? No, I think that's what we put out there so they could draw down whatever increment amounts. It's kind of like when I built a house at one point, at different times, and the contractor come back and said, okay, now we need to have this much brought in. We knew what the guesstimate was, but we brought in at different amounts. Yeah.
Well, and to help us know, is it 50, 40, 30 beds? Or what can we afford?
Right.
Yeah. Okay. Hey, Megan, can you get that down to 5 words, please?
And it might be helpful just, maybe some of the, I don't know whether it's our people out of Division of Budget or, maybe even talking with the county, but I think they understand it.
You want me to read that? Recommend that the State Finance Council release the $15 million appropriated to KDADS for the purpose of opening a new state hospital. Funds should be utilized to begin the development process, including the issuance of an RFP.
Well, we're giving them between now and next year to do this. 'Cause there wasn't a deadline of 22 in there, was there, for the 15 million, Scott? No. It's within our 23 fiscal year. So they got
So-
till July 1, or June 3rd, yeah. Well, not a year and a half. Yeah, July 1, that's it. They've got to get something rolling so they get off a dead center, yes. Yeah, 23.
Well, it'll be 23.
23, because that's where the 15 million is tied to, is 23. Oh, yeah, the fiscal 20, no, okay, yeah, no, it's the fiscal 23, yeah. Don't do that to me. Oh.
Okay. All right, I think what Megan said is good. You're all gonna get this in print later and you can make adjustments if you need to. So, all right, next item.
All right, this is a long one. Hold a meeting with Board of Nursing, BSRB, universities, community technical colleges, state agencies, and other stakeholders to discuss. Bullet 1, LMHT, MHDDT, and other mental health degrees, their transferability and accessibility. Bullet 2, scholarships and other outreach and incentive efforts, such as public-private partnerships. Bullet 3, reducing any barriers that prevent workers from rejoining the workforce once they've retired. Next bullet, a method to track the use of any programs designed to promote the mental health workforce and continually evaluate their efficacy. And last, the wage disparities between mental health providers and other similar jobs.
Megan, can you give me the list of entities you mentioned again? At the beginning of where you started.
Mm-hmm. I have Board of Nursing, BSRB, universities, community and technical colleges, state agencies, and other stakeholders.
Is universities enough, or did we just say K-Board?
Well, I was actually going to add, and private colleges as appropriate or not, or as
Because Newman in Wichita does
nursing.
social
Two
workers.
private colleges that are also involved in nursing. So I just want to make sure
Whoever's providing those jobs out there, we need to have them at the table.
if they're doing nursing. Because, this is such a specialty. You may have just one college that says we'll take it on, or a couple colleges. And then they say we're just going to specialize in this. So,
Well, it's nursing and then your social workers as well.
yeah. Did she say that?
Yeah. Yeah, when she mentioned BSRB.
Okay.
Number
I think
4.
the private colleges have like an organization. It's like our K-Board.
Yeah, I mean,
Okay, so you guys will figure that out.
they have their own boards.
Right.
They're the independent colleges. That's what
Yes,
they are.
there we
yeah.
are.
So you could put independent. You guys, is that everything? I mean, you didn't notice anything missing?
No, it sounded good.
Okay.
Now, once we see it in writing, then it could probably pick it apart, but I liked it.
All right, next one. I mean, you're all in agreement, right?
Mhm.
Okay. We'll go next item.
All right, number 4, appropriate $5 million to KDADS for fiscal year 22 and fiscal year 23 for a two-year pilot program to reimburse hospitals for the supervision of individuals waiting for transfer to a state hospital bed. KDADS will provide an annual update to the legislature by the entities, reporting on the entities receiving funds from the program.
Madam Chair, I don't believe it was 5 million for fiscal 22 and for 23, because 22, by the time the legislature gets back into play, we'll be dealing with the last few months of the fiscal year. So I thought, of the fiscal 23, yes, of the fiscal 23. So it would be for 24. And then somehow we got to figure out a partial, maybe a partial, assuming we can get something started in the 23 year with the balance in a 25 at the 25, up to $10 million. So somehow we have to make it sound, we don't tie it to just a fiscal year, up to $5 million per fiscal year with an up to of 10 for a 2-year period. And that could be a half a year in fiscal 23 and a half of a year in fiscal 25.
So
Does that sound right?
the hospital's responsibility to get whatever that small amount is in the budget.
Yep. Because we can't calculate that right now, today.
Okay, well, let's finish this. I want to go back to the previous one. So go ahead.
Go to the next one.
The
All right.
hospital one. Did you, or do you think that was just clear enough? We got that one. Okay, go ahead and go to the next one.
Okay. Actively look for a contractor to manage the hospital and consider whether a public or private hospital would be best for the state.
Does that go by itself or does that go with the first one? Tie that up in there. Or are we looking at, once the process moves forward, they need to look at both private and state or state? Yeah. Well, I guess then if Sedgwick County builds it, if they get the money, then it would be. So here's the difficult part. We're going to operate it, the state. So somehow the state's got to at least be in a discussion about how it's built. So
You don't necessarily want, I mean, because KDAD's to be the one that says, well, no, we want to be running it. So we're not going to look at the private option, or we will, but we won't really. I mean, there's got to be some guardrails there somewhere because they're the ones that are going to,
right.
so I'm not sure who actually would be looking at it. I mean, it might be Sedgwick County looking at it with the help of, or I don't know. I mean,
Well,
I'm not sure how you do that.
Another hour, I can tell you how the private prison situation went, but and it was difficult, and they left it up to State Finance Council, and it was a lot of meetings, and anyway, the private prison, yeah, so it wasn't. It was not a good process. I'll just put it that way. So we have to figure out how we encourage the state and the county to work together. And Lee, I don't want to put you on the spot because you're just here as a representative, but if you do have anything to add, I mean, feel free. If you know of a mechanism out there that we're not aware of, for the purposes of this report, Scott, you got any ideas? Have you ever seen this? Lee's working her way up slowly.
Lee Cack with KDADS. We would certainly want to be working with Sedgwick County as we move through this process. We're open to suggestions from you all. One option would be, if you're looking at the privatization route, having the state still administer the hospital, like the admissions process, if we had that at a central location along with the other state hospitals, and have oversight of day-to-day operations, but then contract out like the staffing and hiring and that sort of stuff. That would be one way to go, but certainly we could report back to you on once we get the process going.
See, Representative Carpenter, that was one of the things I thought about. They have to have the ability to move people around, since our others are public. You know, when she said have control somehow of at least the admissions. Yeah, they'd have to be the gatekeeper. Go ahead. We're just having a conversation.
Yeah, but that's their hospital. That had nothing to do with us. Yeah, if they wanted to. Yeah, but I just didn't want it to be, people think that KBC was all private. Yeah.
Yes, Senator. Sorry.
Thank you, Madam Chair. KBC run the one in Hayes for years and years and years, and they didn't own it, and they're gonna run the youth facility here next year, and they don't own that facility either, so thank you.
So I'm guessing people closer to this than we are that do this, they'll eventually get this worked out as we continue to grind forward. So. Yeah. Yeah. No, absolutely. Okay. Anything else? The only thing I caught, and maybe I just didn't hear Megan, the suggestion of putting out an RFP for tracking. Okay.
Yeah, in the recommendation about the meeting, I have as a discussion topic, a method to track the use of any programs designed to promote the mental health workforce and continually evaluate their effectiveness.
I was looking for your words, not hers. Anything else? Anything else to come before this meeting? Yes, Megan.
Well, I had two additional recommendations.
Got them down here. Go ahead.
The first is investigate available waivers and reimbursement options that can be used to pull down federal funds to reimburse services provided for mental health services. And then number 6, research how technology such as apps can be used to reach those facing mental health challenges and investigate current practices being used to reach individuals in crisis using technology.
All right. Representative Landwehr.
I just want to thank the chair from Sedgwick for her work and her effort on this and juggling with all of our crazy schedules to get this done, because this is not the end. It's just the beginning of where we're going to head, because it's a long process and a difficult process. So thank you very much.
Yeah. It's been a long journey to get here. So I'm glad we're finally having the conversation. So, all right, if there's nothing else to come before us, we will see everybody on Zoom on December 21st. Please read anything that Megan sends out to you. And if you have any adjustments, that just she'll let me know. And then we'll get out an agenda and the invitation list for the 21st. Seeing nothing else coming for us, we are adjourned. Thank you all, committee. You did a great job. Good work.